Dear God, thank you for the opportunity to meet together. Please help us to come together to make this institution reflect your kingdom. Breathe life into our ideas and decisions. Help us build a team that has love and respect at its heart. Give us the strength to continue working for your kingdom in this time of pandemic. Lord, come give us the inspiration to be the best we can be. May we be a shining example of your goodness and truth within, wherever we are. Inspire our thoughts, discussions, and ideas, and continue to remind us that all that we do here today, all that we accomplish, we ask these things in your name. Amen.
Okay, good morning again. Can I request all of you to open your your cameras? All right, don't worry. It will be just for this time. Okay, later on you can do whatever you want. I mean, you can turn off your camera. All right, because the admin is taking an attendance. Okay, so we're 30. You're 30. It's yeah, quite a lot. Okay, thank you for opening your cam. Okay, so let's have a little chit chat before we begin. Okay, let me introduce first myself. My name is Rowell Kolala. Okay, I am one of the instructors of we pump the industry for quite a while. Yeah, for almost 10 years. Okay, I facilitate the different programs of the American Safety and Health Institute. Okay, we have, aside from the BLS and ACLS, okay, I also facilitate basic and advanced first aid, okay, and pediatric advanced life support. Okay, and of course, okay, the emergency responders course. Okay, the emergency medical responders course is just like an advanced first aid, but with a mass casualty incident consideration. All right. Okay. Now, the WIPOM Training Center, okay, is one of the training centers under the American Safety and Health Institute as a local provider, okay, in the Philippines, right? And it is based in Naga City, okay, in Bicol, right? So who are from outside Bicol region here? Meron po ba? Si Ma'am Marie, Arianet, kaya si Janice, kay who else? Wala na? Okay. You can unmute, guys. No? Okay, if you feel you feel talking to me. Okay. Okay. And of course, okay, since we have a local provider, okay, it won't be materialized no, without the international accreditation, that is the advanced cardiac life support. I mean, it's the American Safety and Health Institute. Okay, all right. So the American Safety and Health Institute is just like American Heart Association. Okay, we healthcare providers, both healthcare providers and non-healthcare providers, give for the different programs. Okay, the only difference compared to the American Heart Association is just the organization. Okay, the name of the organization and the fee, okay, for the training. Okay, but all the organ umbrella, and that is ALCOR, or International Liaison Committee on Resuscitation. So it means that all standards and recommendations, okay, must uh, the International Liaison Committee on Resuscitation together, okay, to talk about the studied guidelines, the researches, and their recommendations regarding the emergency, or specifically the emergency cardiovascular care. All right. Okay. Now I would like to welcome you all, okay, to our ACLS training. Okay, we have a compressed 2 days of this training. Okay. Which is supposedly 3 days if we are in face-to-face type of class. Okay, because we have a lot of skills demonstration, okay, if we are in face-to-face. But since we are in online, okay, I will be giving you instructional videos, okay, to as an alternative, okay, for these skills, okay, in your practical demonstration. All right. Okay. So for this morning, okay, you will be expecting the basic life support only alone, okay, with a lot of video instructions and presentation. Okay, and we hopefully finish the discussion at 10:30 or 11, okay, to give way for the post test. Yes, you have post test after the BLS. And yeah, you have an hour, okay, for the post test, resuming at 1 p.m. for the advanced cardiac life support. Okay, okay, so that is our piece. Okay. Any question? Any question? Okay, so that would be great. This afternoon, okay, we will start the ACLS with the EC discussion. Okay, and I think it will take us 3 to 4 hours, okay, to finish, okay, the discussion. Okay, but if we finish the ACLS for 3 hours, okay, we will consume the 1 hour, okay, for the therapies, and I mean the algorithms, okay, that will discuss the therapies. Okay, so tomorrow, okay, so tomorrow we will we can finish, the discussion in ACLS in or earlier, okay, than the usual time activities. Okay, all right. Any question? Okay, now if you have questions, okay, while the video is playing, okay, you can just use the chat box. Okay, and every after the video presentation, okay, we will have, or I'm going to ask you, okay, if you have questions, and um we can talk about it, uh but make sure it's related on the topic, okay, the discussed topic. Okay, so do we have a doctor here? So because I always address in a first name basis, kaya lang medyo napagalitan ako doon, no? Okay, so do we have a doctor here? May I know? Or I'm so sorry. I get used to calling persons in their first names. But yeah, to call you, okay, or how to address you, especially our doctor. Okay. Okay, so who are in duty? Do we have participants here on duty? Wala po. Okay. Okay, from duty. Okay, from duty. Okay, so I assume you're not exhausted enough to listen to me. Okay, because sometimes I or the participants not get bored, no, get with me, is uh I usually unaware of my voice. Okay, medyo parang from 6 feet No, anyways, all right, just feel free to butt me in every time I speak. Okay, it's your right. Okay, if ever you have any question, okay, especially if the video and the audio, okay, presentation is or are just or are lagging. No? Maybe I can fix it first. No, okay, before we continue. All right. Any question so far? Okay. All right. Okay, so let's begin the discussion with the introductions, no? Okay, and the basic life support. Okay, it is I'm going to share my screen now. Oh, yeah. Okay, so the outlines for the introduction of the basic life support video presentation are how to prepare to respond, the the definition and the basic principles in sudden cardiac arrest and secondary cardiac arrest. Of course, the highlight, okay, for the high performance CPR, how we protect ourselves, okay, that is related to infection prevention and control, both pre-hospital and in-hospital scenario, and how we call for help. All right, because of course, okay, after the introductions, we will have the foundation of the basic life support, which are the skills. Okay, we have the chest compression, we have the rescue breathing, we have the automated external defibrillation, and the BLS assessment. All right. Okay, so these are actually our focus on the skills or the high quality performance, not in basic life support. Okay, and of course, okay, we have the care, okay, the BLS care. So we have caring for an individual under the respiratory arrest, under the cardiac arrest, and considerations for the multiple provider approach. Okay, okay. A supplemental topic, which is the choking or the management or the foreign body in airway obstruction, okay, will be also be presented. Okay, all right. Okay, now I'm gonna turn off my camera, okay, to the connectivity or the connections of the internet. You can do the same. All right. Okay, again, okay, don't forget to use your chat box, okay, for any questions or concerns. Okay.
Jason! Jason, can you hear me? Oh no.
911, what's the address of the emergency?
Press 50 Wheeler Road, Oakdale.
LFA Station 1, Medic 5, possible cardiac arrest, 50 Wheeler Road, Cross Villard.
And is he breathing?
No, he's not breathing. Please help.
Dispatch LFA Engine 105 en route to 50 Wheeler Road.
Copy Engine 1 en route to 50 Wheeler. Update on patient, 60-year-old male. Bystander CPR is in progress.
Copy. CPR in progress.
Go ahead and set your phone down, put me on speaker.
Hold on.
Okay, can you hear me?
Yes.
Okay, let's get him flat on his back. I'm going to tell you how to do CPR. Okay, I want you to put one hand on top of the other, right in the center of his chest.
Okay.
We're going to pump the chest hard and fast, at least 2 times per second and 2 inches deep. We're going to do this 600 times or until help can take over.
Okay.
This is the pace that I want you to do. It's 1, 2, 3,
breathing stops. Sudden cardiac arrest occurs when the normal electrical impulses in the heart suddenly become disorganized. Normal mechanical contraction of the heart muscle is lost, and a chaotic quivering condition known as ventricular fibrillation can occur. Blood flow to the body, along with the oxygen it carries, abruptly stops. Within minutes, brain cell death starts to occur from the lack of oxygen.
Fire department! In here! We're in here! Hurry!
Okay, let me in here.
Okay, thank you.
Sir, are you okay? Confirm cardiac arrest.
Cardiopulmonary resuscitation, or CPR, is the immediate treatment for a suspected cardiac arrest. CPR can restore limited oxygen to the brain and other vital organs through a combination of chest compressions and rescue breaths. However, CPR alone is not enough.
1, 2, 3, 4, 5, 6.
The most
7.
effective way to end fibrillation is defibrillation, using a defibrillator and electrode pads adhered to the chest. A controlled electrical shock is sent through the heart to stop ventricular fibrillation, allowing the heart's normal electrical activity to return and restore the normal pumping action of the heart. Successful defibrillation is highly dependent on how quickly a shock can be delivered. For each minute in cardiac arrest, the chance of surviving goes down by about 10%. After as few as 10 minutes, survival is unlikely. An automated external defibrillator, or AED, is a portable, computerized device that is simple to operate. The use of AEDs by emergency responders and other healthcare personnel allows defibrillation to occur much earlier than before. Turning on an AED is as simple as pushing a power button. Once on, an AED provides voice instructions to guide an operator through its use.
Apply pads to patient's bare chest.
19, 20, 21, 22.
An AED automatically analyzes the heart rhythm to determine if a shock is needed.
Stay clear of patient. Analyzing.
If a shock is advised by the AED,
Shock advised.
Everyone clear?
the operator clears the person and pushes a button to deliver the shock.
Shock delivered. Begin
Immediate
CPR.
high-quality CPR and early defibrillation with an AED can double or even triple the likelihood for survival. Most cardiac arrests occur outside of a hospital. Most of those occur in the home. The chain of survival is often used to describe the best approach for treating cardiac arrest. Each link in the chain is essential for a person to survive. If a single link is weak or missing, the chances for survival are greatly reduced. The greatest chance for survival exists when all the links are strong. The chain of survival for cardiac arrests outside of a hospital consists of 5 interdependent links: early recognition of cardiac arrest and prompt activation of the emergency response protocol for the setting, immediate CPR with high-quality chest compressions, rapid defibrillation or electrical shock to the heart, effective basic and advanced EMS care and transport, and effective post-cardiac arrest care at a hospital. Cardiac arrest inside a hospital usually occurs when a known medical condition worsens. The chain of survival inside a hospital reflects how resuscitation fits into the overall picture of medical care: monitoring, prevention, and treatment of pre-arrest conditions, early recognition of cardiac arrest, and prompt activation of the emergency response protocol for the setting, immediate CPR with high-quality chest compressions, rapid defibrillation or electrical shock to the heart, and effective post-cardiac arrest care.
All right. Okay, so that is the definition of the cardiac arrest. Okay. All right. Can anyone tell me the definition of the cardiac arrest based on the video presentation? Okay, I'm sorry. I ask questions from time to time, but if you do not feel to answer the question, yeah, it's still okay. All right. Okay, so the cardiac arrest is the case that we should take into consideration in basic life support. Okay. All right. So basic life support is the immediate management, okay, that a provider can provide, okay, to manage the patient under cardiac arrest and or respiratory arrest. Okay. All right. So if the patient is not in respiratory arrest or not in cardiac arrest, then we cannot do the basic life supports principle. Okay. All right. For example, okay, the patient is conscious, okay, and with breathing and with pulse, okay, but with bleeding or with wound, okay, we have to apply the first aid principles. Okay, not the basic life support. Okay, just remember, okay, that the case that we should take into consideration in basic life support, okay, are those patients under respiratory arrest and or cardiac arrest. All right. Okay, now to manage the patient in respiratory arrest and cardiac arrest, okay, we need to follow, okay, the chain of survival. Okay, the chain of survival is our guide, okay, to give, okay, the management to the patient. Okay, for example, okay, if you are walking across the street and you notice a patient on the ground, okay, what is your first step, okay, to do? Okay, all right. So the chain of survival, okay, is a clear picture of what we should do to the patient. Okay, for example, the first chain of survival in out of hospital scenario, okay, is to recognize the signs of cardiac arrest. Okay, and right after recognize the signs of cardiac arrest, okay, we need to immediately activate the EMS. Okay, and that is calling for help. Okay, that is the first thing to do that a provider must take into consideration. Okay, all right. The second chain of survival, okay, is the early CPR, right? So that is why we need to know, okay, the high quality chest compression, okay, and the rescue breathing. Okay, all right. The third, okay, is the early defibrillation, okay, by the use of the AED. Okay, defibrillation is somehow, I'm sorry, is my audio clear? Can anyone tell me is my audio clear? I forgot to. Yes, okay, loud and clear. Thank you so much. Okay, sana ko. Yeah, okay, the defibrillation is somehow advanced, okay, and if you think about it, okay, it must be under the advanced cardiac life support, okay, but now in basic life support, okay, we are introducing the use of the automated external defibrillator machine. Okay, that is a small portable device, okay, the ventricular fibrillation. Okay, all right. It was introduced way back year 2000. Okay, where or after, okay, the study conducted by the American Heart Association that 90 to 95 or 80 to 90%, okay, in cardiac arrest demonstrates ventricular fibrillation. Okay, and the only management, okay, or the only thing that can treat, okay, the ventricular fibrillation is the application of the electrical shock. Okay, but of course, okay, when we're talking about electrical shock, we need a manual defibrillator machine, and that is somehow heavy, okay, when it is carried, okay, by a healthcare, or I mean the emergency medical service. Okay, So they develop, okay, a small portable device that can able to give the same electrical shock that a manual defibrillator would do, okay, in the hospital setting. All right, so that is the third um, chain of survival. Now, um, the chain of survival is called chain, okay, to emphasize that each chain, okay, must be connected, okay, to each other, okay, and there must be no chain that should be disregarded. Okay, for example, you've already done, okay, the first chain, okay, but you did not continue, okay, to the second, okay, which is the CPR, okay. All right, and we all know, okay, that CPR is the foundation of the basic life support. So without the CPR, the patient may not be able to survive. All right, okay, right. For example, okay, we've facilitated the first chain, the second chain, and we did not deliver the electrical shock. Okay, the patient may not survive if the patient's heart is demonstrating the ventricular fibrillation. Okay, because again, okay, the only thing that can treat the ventricular fibrillation is the um, application of the electrical shock. All right. Okay, now okay, so that is the reason why, okay, we have this chain. All right, the fourth chain of survival, okay, is the transport. Okay, it means that let's say, for example, the scenario is out of hospital scenario or pre-hospital scenario, okay, and we've already facilitated the CPR. We already provided the CPR, and there is an EED, okay, but there is no EMS, okay, that can transfer the patient to the definitive hospital. Okay, the chance of survival, okay, is also, okay, less than what we should expect, because the cardiac arrest, okay, may be recurrent, okay, or it can recur, okay, especially if the cause of arrest, the immediate post-cardiac arrest care, okay, that is in the hospital, okay, or it must be facilitated inside the hospital, okay, and that is from the admission of the patient, okay, to the and prevention of the of arrest. It is here, okay, to the attending physician of the patient. All right. Okay, so that is the chain of survival in out-of-hospital scenario or pre-hospital scenario. Now let's talk about the chain of survival in the in-hospital scenario. Okay, it's quite different, okay, from the principles, okay, of the pre-hospital scenario. Okay, all right. In the sense, okay, that since the patient is already in the hospital to treat the patient, okay, the first chain of survival, okay, is we have to prevent, okay, we have to monitor and prevent the from happening. Okay, that is the first chain. Okay, the second chain, okay, is the recognition and activation of the emergency response protocol in the hospital. Okay, all right, so EMS, okay, is for out of hospital scenario. Okay, that is the 911. Okay, we will going to discuss that under the calling for help principle. But can we call for 911 if we are inside a hospital? Okay, no, it's not applicable. Okay, because the emergency response protocol inside a hospital is the code blue. Okay, so you need to call the code blue in order for the patient, okay, to be resuscitated. Okay, so you must know the how, okay, you call for the code blue in your facility. All right. Okay, so the second chain of survival in the in-hospital scenario is the first chain of survival in the out-of-hospital scenario. Okay, the third chain of survival is the CPR, and the fourth chain of survival is the defibrillation. Okay, All right, we do not have a transport chain, okay, in hospital scenario because, of course, okay, the patient is inside the hospital, so we might not need to transfer the patient from another hospital, okay, unless, okay, your hospital is just a primary hospital or infirmary, okay. Okay, now the fifth chain of survival is the immediate post-cardiac arrest care, okay, which is very similar to the fifth chain of survival in the out-of-hospital scenario. Okay, and there is, okay, a recovery phase, okay, via sixth step. Okay, all right. So let me know, okay, if I'm getting too fast. All right, okay, because some of you are taking notes. Okay, I'm not aware, okay, that I'm getting too fast. Okay, definition of cardiac arrest, chain of survival. Yes, okay, the cardiac arrest, okay, is as we all know, okay, the cessation, okay, of the normal function of the heart, okay, which is the pumping action. Okay, so if there is no pulse, okay, there is no circulation. If there is a circulation, the heart is not pumping. Okay, that is the cardiac arrest. Okay, or simply the cessation, okay, of the heart's function. Okay, all right. The chain of survival, okay, is a chain of management, okay, that a provider, okay, must take into consideration, okay, to promote a higher rate of or a higher chance for the patient to survive. Okay, without the chain of survival, or without following the chain of survival, okay, there is or the chance of survival of the patient is less than what we should expect. All right. Okay. All right. Now that is, okay, for the adult chain of survival. Okay, we have a different chain of survival in infants and children. Okay, so before I play, get the secondary cardiac arrest, do you have any question? Okay, I suppose we can continue, okay, to the second video.
Engine 2312, dispatch.
Engine 2312.
I have an update on patient condition. Caller reports patient was caught in a fallen tree and submerged for several minutes. The patient is now out of the water, and we're attempting to get bystander CPR initiated now.
Copy, dispatch. Engine 2312. On scene now.
Copy, 2312 on scene.
He got caught up on a strainer. I just got him out.
Sir, can you hear me?
Unlike sudden cardiac arrest, in which the heart is the primary problem,
No pulse.
cardiac arrest can also be the end result of a blocked airway or loss of breathing. This is known as secondary cardiac arrest.
Apply pads to patient's bare chest.
Problems such as hazardous breathing conditions in a confined space, drowning, and drug overdoses are all causes of secondary cardiac arrest. With no incoming oxygen, the heart progressively becomes weaker until signs of life become difficult or impossible to assess.
Stay clear of patient. Analyzing. Stay clear of patient. No shock advised. Begin CPR.
Medic 849, engine 2312.
If the heart is simply too weak to create obvious signs of life,
Cardiac arrest.
immediate CPR with an emphasis on effective rescue breaths may be the only chance to restore them. The abuse of opioid drugs is a serious and growing health problem. Increasing prescriptions for opioid pain relievers such as hydrocodone and oxycodone have made them more commonly available. The increased availability and use of heroin, a highly addictive opioid, is also contributing to the problem. As a result, overdoses and deaths from prescription opioids and heroin have risen dramatically. Opioids taken in excess can depress and stop breathing. Opioid overdose is a common cause of secondary cardiac arrest. Suspicion of opioid use may present itself through questioning of bystanders or by observation of the person and location in which she was found. Naloxone, also known as Narcan, is a medication that can temporarily reverse the life-threatening effects of opioids. It's easy to administer, either through an auto-injector device or through an aerosol that is sprayed into the nose. Initiate and establish BLS care prior to using naloxone for suspected opioid overdose.
Do you hear me? Hello? Hello?
Command, this is Engine 105.
This command, go ahead.
We have a child in cardiac arrest at our location. We need a medic unit right away.
Copy that.
Children are more likely than adults to experience secondary cardiac arrest due to an airway or breathing problem. When describing age groups in relation to CPR, an infant is younger than 1 year of age. A child is 1 year of age until the onset of puberty. Puberty can be identified by breast development in females and the presence of armpit hair in males. A person is considered an adult after the onset of puberty. The chain of survival for children and infants emphasizes prevention and giving effective rescue breaths as part of CPR. Prevention of airway and breathing emergencies. Early CPR with an emphasis on effective rescue breaths, and if needed, defibrillation with an AED. Prompt activation of the emergency response protocol for the setting. Effective basic and advanced EMS care and transport, and effective post-cardiac arrest care at a hospital.
Okay, can someone tell me the difference in cardiac arrest or chain of survival in infants and children, okay, and adult? Of course, okay, there is okay, a major difference. Okay, all right. Can someone give me that difference? Okay. All right, now.
Hey lang, sir.
Yes, speaking, please. Sorry.
Try lang po. Try lang.
Speaking.
Yung sa infant po ba, because due to respiratory arrest, yung magka-problema muna sa breathing. Tapos yung sa adult, maybe due to opioid use or substance use, bago nagkaroon ng secondary cardiac arrest.
Yes, that's great. Okay. What's the difference in chain of survival in adult and that of the children and infants? Can you tell me the difference?
Kung ano kung CPR pa, kailangan ba ng CPR kaagad?
Yeah. Well, yes.
Wala kasing bullet form. Kakaano lang. Mas maganda kung naka-bullet form.
Yeah, that's okay. Okay. All right, yes. Thank you so much, Mineta. Okay. Were you the one who gave the answer? Identifying first stage. Okay. According to Kambal, no? Okay, the identifying first stage. All right, that's great. Okay, all right. Now, the first step, okay, of the chain of survival in infants and children, okay, is the prevention, okay, of the respiratory arrest. Okay, I mean, yes, prevention of the breathing emergencies. Okay, to prevent the respiratory arrest from happening. Okay, all right. This respiratory breathing emergencies, okay, are drowning, okay, choking, okay, and all. Okay, all right, because unlike in adult, okay, where the major cause of the cardiac arrest, okay, is cardiovascular, specifically the electrical or the development of dysrhythmia. Okay, in infants and children, okay, the main cause of cardiac arrest, okay, is the respiratory emergencies. Okay, just like what Minette said. Okay, all right. So that is the main difference. Okay, and the chain of survival. Okay, for the adult and children. Okay, children and infants. Okay, all right. If in adult, okay, we need to recognize, okay, the cardiac arrest. Okay, and or prevent, okay, the cardiac arrest from happening. Okay, in infants and children, okay, the first thing to do is to prevent the emergency or the respiratory emergency from happening. Okay, right. But if the second chain of survival, okay, is the recognition, okay, of the cardiac arrest. Okay, if um the cardiac arrest, okay, happens, okay, to children and infants. Okay, but also, okay, we need to take into consideration when, okay, to call for help. Okay, all right. The calling for help, okay, in children and infants is not the same, okay, with the calling for help, okay, or the timing in adult chain of survival. Okay, for the out of hospital scenario is the first chain, is under the first chain. Okay, in hospital scenario, okay, that is the second, okay, the second chain. Okay, in the infants and children, okay, it is actually the third. Okay, so let's go back, okay, to the first chain of survival in infants and children. Okay, the first chain, okay, is the prevention of the breathing emergencies. The second, okay, is the management, okay, the CPR, okay, with high emphasis on the rescue breathing and defibrillation if applicable. All right, okay, if applicable, okay, only, okay, due to the non-involvement, okay, of the cardiovascular system. Okay, all right. The third, okay, is when you call the third, okay, is actually, okay, the chain of survival, okay, where you call, okay, for the EMS, okay, or help. Okay, because in children and infants, you need to perform at least 2 minutes of care before calling for EMS. Okay, because again, okay, the cause of arrest, okay, is just secondary, okay, to the respiratory arrest. Okay, clear? I hope I'm clear in that principle. Okay, all right. Yeah, all right. Yes, Minera. Okay, the first chain is prevention of respiratory emergencies. The second is the CPR, okay, with high emphasis on the rescue breathing, and AED application. AED is under the third, okay, chain of survival, and the fourth chain of survival. Okay, all right. The third, yes, is calling for EMS and help. Okay, and the fourth and the fifth, okay, are the same with that of the adults. All right, principle, okay, in the case, okay, of the infants and children. Okay, any question? Question? Okay. All right, so that's good. Okay, maybe we can play the next video.
The quality of CPR matters. Higher quality CPR performance is directly related to an improved chance of survival. There are two key elements of high-performance CPR: high-quality CPR skills and a more efficient team approach to resuscitation. CPR skills can vary greatly depending on a person's experience, practice, and physical ability. It is normal for there to be a gap between perfect skills and what you can actually perform. An important goal is to narrow that gap as much as possible. High-quality CPR skills include beginning CPR compressions within 10 seconds of determining cardiac arrest, compressing fast at a rate of 100 to 120 times per minute, compressing hard at least 2 inches on an adult and at least 1/3 the depth of the chest for children and infants, allowing for complete chest recoil at the top of each compression, minimizing interruptions to compressions, giving effective rescue breaths that create a visible chest rise, and avoiding excessive air on rescue breaths. CPR feedback devices that measure skill performance in real time can be used to optimize CPR. High-quality skills are only part of high-performance CPR. Orchestrating the actions of a resuscitation through a team approach, much like a pit crew in a car race, can significantly improve the care being provided. An effective team approach has clearly defined roles, uses clear and effective communication, allows multiple treatment actions to occur at the same time, maintains high-quality CPR by allowing team members to switch places when tired, and minimizes overall interruption times. The only way to develop a high-performance CPR approach is through ongoing commitment and practice. CPR skills can deteriorate significantly in as little as 3 months. Shorter, more frequent, scenario-based retraining sessions are reasonable for maintaining skills for individuals likely to respond to a cardiac arrest.
Okay, we're not going through this because we have a separate topic for high performance CPR. Okay, we will continue with protecting yourself.
Emergency situations often present hazards to your safety and health.
He's over there. He was mixing chemicals and fell.
Okay.
Your personal safety is the highest priority, even before the safety of an ill or injured person.
Go and get hazmat on. Tell me we got one man down as an unknown chemical.
Putting yourself in danger to help someone can make the situation worse. Always pause for a moment before approaching. Look for obvious hazards. Consider the possibility of hidden dangers. If the scene is not safe, do not enter it until hazards have been minimized or eliminated. When caring for someone, you can be exposed to blood or other potentially infectious body fluids. While the risk of contracting a disease is very low, you must take measures to reduce exposure. The most common infection bloodborne diseases and pathogens include hepatitis B, hepatitis C, and HIV, the virus that causes AIDS. Standard precautions is a set of protective practices used when providing care, whether or not an infection is suspected. Personal protective equipment, or PPE, describes protective barriers worn to prevent exposure to infectious diseases. Reducing exposure lowers the chance of infection. Disposable gloves are the most commonly used barrier. Make sure they are readily available and always use them. To prevent direct contact, use a CPR mask with a one-way valve when giving rescue breaths or a bag mask device to prevent direct mouth-to-mouth contact. Unprotected mouth-to-mouth rescue breaths should not be given by emergency response personnel.
Okay, so regarding the protecting yourself topic, who would you think would receive the highest allocation of safety? Okay, if you are given 100% allocation of safety, okay, how would you divide that 100%, okay, into 3 groups? Okay, you as a provider, okay, for the patient and for the bystanders. Okay, how would you divide 100% allocation of safety? Okay, who would you give the highest priority of safety? Okay, anyone? Come on, guys, you can use the chat box. Okay, if you don't feel like talking. Yeah. All right. Some other some say rescuer, other for provider, other for bystander, provider, yes. Protecting yourself first. Okay, all right. Yes, okay. All right, thank you so much, okay, for the answers. Well, actually, okay, if it depends on the scenario, okay, but if we are talking about out of hospital scenario, okay, the highest priority for the safety must be yourself. Yes, okay, it must be the provider, okay, because if you become the casualty, there will be no basic life support that will pursue, okay, or there will be no rescuer, okay, that will continue, okay, the management, okay, in basic life support. Okay, all right, so you might give yourself or the provider an like 90%, okay, of the safety, okay, and 5% for the patient and 5% for the bystander, right? Okay. Okay, well, actually, okay, if you do not want, okay, to attend, okay, the patient's needs, okay, in any kind of life support principles, okay, it is proper, okay, it is applicable, and it is, um, you know, um, if you don't feel like doing it, okay, due to the or for the reason, okay, that your health will be in danger, okay, or will be compromised, okay, then you the least thing, or the best rather, the best thing that you can do is to call for help. All right, okay, all right. Now, how are we going to protect ourselves? Okay, all right, let's say for example you're cross the street, okay, you're crossing the street, and you notice a patient on the ground, okay. Before attending the patient's needs or before approaching the patient, okay, you have to observe, okay, or survey the scene, okay, for any hazard, okay. All right, those hazards are fire, wind, water, okay, what else, earth, okay, right, and even the living things, okay, I mean the living creature, okay, the animals, okay, all right, specifically if you are doing some outdoor activities, okay, in the Philippines, okay, we have a lot of snakes, okay, you can even actually, you can even find snakes beside you, okay, or your best friend. Okay, it's a joke. Okay, after serving the scene and the scene, okay, has been made clear, okay, you can approach the patient, okay, and of course, you do not know, okay, the history of the patient, okay, right? You do not know if the patient has a contagious disease and infectious disease, okay? So it's better for us to have a barrier device, okay? In out-of-hospital scenario, okay, the barrier devices that I'm talking about, okay, are the overlaying CPR shield, okay, or overlaying CPR shield and the valve mask, okay, as shown, okay, in the video, okay. The valve mask, okay, are often used by the emergency medical services, okay, to rescue, to attend, okay, the patient's need, or to attend the patient's or to provide, okay, the rescue breathing, okay, during the an event, okay. But of course, no, okay, for us, okay, that who are not emergency medical service and practitioner, okay, I mean, yes, we are a healthcare provider, but we are not emergency medical service practitioner, okay. The best thing that we can do to provide rescue breathing is through mouth-to-mouth resuscitation, okay. That is barely introducing the air, okay, from you, okay, to the patient, okay. All right, in that case, okay, there is a possibility of cross-contamination of the disease, okay. So again, okay, if you do not want, okay, to do that, okay, it's okay, all right, okay, as long as we the reason, okay, is our health. All right, okay. Now in first aid, okay, and in basic life support, okay, aside from that overlaying CPR shield, okay, and the mask, the valve mask, okay, there is no recommended alternative, okay, for doing, okay, the rescue breathing. Okay, but some say that you can use your handkerchief, okay, to to use as a barrier, okay, or your shirt, okay, or your clothes, okay, or a plastic, okay, to provide the rescue breathing. Okay, but yes, okay, those are very industrious. Okay, but there's no recommendation for that. Okay, so we just stick, okay, with the standard. Okay, all right, that is for out of hospital scenario. Okay, now in the in hospital scenario, of course, okay, we always talk about patient safety. Okay, all right, we always prioritize the patient safety. Okay, but it doesn't mean that we disregard, okay, the safety of ourselves, okay, as a provider. Okay, and to provide us, okay, with safety measures. Okay, of course we have the PPEs. Okay, we have the personal protective equipment. Okay, and the bag mask. Okay, and the hospital. Okay, the bag mask is also known as the ambu bag, okay, in the Philippines. Okay, but in general, okay, it must be called bag valve mask. Okay, bag valve mask, okay, or BVM, or simply a bag mask, okay, or simply a bag resuscitator, a manual resuscitator. Okay, all right, so that's how we protect ourselves. All right, any question regarding the protecting yourself topic? Any question, clarification, or any comment? Okay, if none, okay, I will be playing the last video for our introduction.
BLS providers and the locations in which they work vary. So does the way in which they activate a response for higher levels of care. Activation is typically defined by emergency response protocol. A BLS provider or member of a workplace emergency response team may radio a centralized communication person to contact EMS, or the provider may call EMS directly. An EMS provider may request help from advanced care providers or inform other incoming responders about the details of the situation found. Inside a hospital, a floor nurse may call a code to which a resuscitation team with appropriate equipment will respond. To be an effective BLS provider, you must understand your local protocols on how to call for additional help.
Okay, how would you call for a help? Okay, for example, okay, you've already approached the patient and you recognize that the patient is under cardiac arrest. Okay, so how would you call for help? Anyone? Anyone? Hello, guys. How would you call for help? Let's say, for example, the scenario is out of hospital. Yes. Josefina, are you talking? I cannot hear you. Okay, according to Minera, okay, you have to have a bystander, okay, to do it. Okay, yes, no, okay, that's great. Okay, especially, okay, if you are, okay, around the a lot of bystanders, okay, right, you have to point to someone, okay, and say help. Okay, call 911 or activate the EMS. All right, or send someone. Yes, get emergency, the emergency number, okay, or the standard emergency number in the Philippines is 911. Okay, if you're not aware, still not aware that we have 911 in the Philippines, okay, then this is the best time, okay, all right, to take that into consideration. Okay, if you call for 911, there is actually an operator that will ask your name and your location. Okay, then that operator would endorse you to the nearby municipality or city, okay, where there is an EMS. Okay, and that is, yes, happening in the Philippines. Okay, if out of hospital with bystander, shout for help. Yes, okay, from RB. Okay, from Marie, bystander to call for help. Yes, those are correct. Okay, all right. Now that is okay if there are bystanders. Okay, but if there is no bystander and you are alone with the patient, for example, dating someone, and um you are, how would you, if for example there is no bystander, okay, you're alone with the patient, leave the patient to activate EMS. Yes, okay, Ruvalin, okay, you have to leave the patient and activate EMS. Remember the chain of survival. The first chain is to recognize and call for the EMS. You do not um you should not provide the CPR without calling for help, because eventually you will get exhausted. Okay, and the tendency is you stop your CPR, okay, without someone, okay, arriving and taking over your place. Okay, so it's very crucial. Okay, if you get exhausted and there's no one to continue, okay, with the CPR, all right, in all types of cases. All right, okay, so if you're alone with the patient, okay, in a confined space, okay, you have to leave the patient and get help. All right, okay, until you get someone, okay, to call for help and go back to the patient to perform the CPR. Thank you so much. Okay, all right. Okay, thank you so much for your participations. And since we are, or the time, okay, is already 9:08, okay, I forgot to tell you that every hour I would give 10 minutes of break, okay, just to freshen up our minds and focus. Okay, all right, so it's 9:08. We will resume at 9:18 with, okay, the foundation topics, okay, the chest compression and the rescue breathing. Okay, all right, so see you after 10 minutes. 9:18. I hope everyone is here. Okay, so for those who are asking, okay, about the lunchtime, okay, it will be 12 to 12:30, okay, and your post test would be 11 a.m. to 12 noon. Okay, so I guess that would be enough time, okay, for you to accomplish your test. Okay, and since we are all online, okay, 30 minutes would be enough, okay, for your lunch. Okay, all right, okay, let's continue the video discussion, okay, with the chest compression. Okay, again, okay, the foundation and basic life support or the chest compression, the rescue breathing machine, okay, of the how we do or how we perform the high quality chest compression.
used to provide the most effective approach to cardiac arrest. These include high-quality chest compressions, high-quality rescue breaths using a CPR mask or bag mask device, emergencies using a BLS assessment. External compression of the chest increases pressure inside the chest and directly compresses the heart, forcing blood, heart, brain, and the rest of the body. To perform proper compressions, the person needs to be positioned on his or her back on a flat, firm surface. Kneel close to the side of the person. Place the heel of one hand on the center of the chest on the lower half of the breastbone. Place the heel of your other hand on top of and parallel to the first. Bring your body up and over the chest so your shoulders are directly above your hands. Bending at the waist, use your upper body weight to push straight down to a depth of at least 2 inches. Lift your weight and allow the chest to fully return to its normal position. Move immediately into the downstroke of the next compression. Focus on high-quality techniques. Compress deeply more than 2 inches. It is likely you will not compress deep enough. While injury could occur from deeper compressions, do not let the fear of this affect compression depth. Compress fast, between 100 and 120 times per minute. Do not let a higher compression speed result in a shallower compression depth. Do not lean on the chest between compressions. Blood pressure is created and maintained with ongoing compressions. When compressions stop, pressure is quickly lost and has to be slowly built up again. Allow the chest wall to fully recoil or rebound at the top of each compression. Minimize interruptions when doing compressions. When compressing you may hear and feel changes in the chest wall. As an alternative approach, you can grasp the wrist of one hand with the other when it is difficult to compress with the heels of both hands. To perform chest compressions on a child, position the child face up on a flat, firm surface. Place the heel of one hand on the lower half of the breastbone, just above the point where the ribs meet. Using upper body, compress at least 1/3 the depth of the chest, or about 2 inches. Lift your weight and allow the chest to return to its normal position. Without pausing, continue into the downstroke of the next compression. Continue compressing at a rate of 100 to 100 compressions per minute. Remember to compress fast and deep, and allow the chest to recoil to its normal position at the top of each compression. When doing chest compressions with 2 or more providers, encircle the sides of the chest with your hands and use your thumb tips to compress the lower third of the breastbone.
Okay, so that's how we do the high quality chest compression. Actually, we have to follow the 5 components of the high quality chest compression, right? Can someone tell me, according to the video, okay, the components of high quality chest compression, how we should do the compression in order for it to become high quality? Okay, anyone? Anyone from the group? Components of high compression. Very good. Okay, what else? Minimizing interruption. Yes, Clarizel. Okay, that is good. Rate of 100 to 120, okay, per minute. Okay, Julius, yes, 100 to 120 per minute. Okay, not per cycle. Okay, chest compression fraction of greater than 80% AS, right? Chest compression of 120 per minute. Okay, Christine, yes, avoid excessive from Maybell. Okay, what else? The principle of in layman's terms, okay, fast and deep compression. Okay, 1/3 the depth of compression depth 2 inches for adult and 1/3 the depth of chest for infants and children from Mabel. Starting compression within 10 seconds of recognition. Yes, Clarizel. Okay, hand or finger placement. Okay, yes, Minetta. Yes, okay, yes. All those are the components, okay, of the high quality chest. Okay, right, great. Now, I would just like to add the proper body mechanics. Okay, right. Of course, before you perform all those have mentioned, okay, you need to know how to position yourself, okay, beside a patient, or if not, it's really applicable that you need to position body okay, but if the patient is in hospital scenario, okay, we need to step on the footstool. Okay, that is a counterpart of kneeling close to the patient's chest, because that principle, okay, should be before we start our CPR, okay, our knees must be at the level of the patient. Okay, so by kneeling close to the patient's chest, okay, our knees will be able to be at the level of the patient, and by stepping on the footstool, okay, we can reach, okay, the level of the patient on the bed. All right, okay, because if we do not do that, okay, we cannot able to position our upper body, okay, on the patient's or above the patient, okay, right, or specifically on the patient's chest, okay, because we need to straighten our arms, okay, we need to align our arms and shoulders directly perpendicular on the patient's chest. Okay, now let's take a look at the
In this practice, you will perform chest compressions by following along with the video demonstration. Each person should have a mannequin. You will do 2 sets of 30 compressions. If you need more practice, when it ends. Run the segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1.
All right. As I mentioned a while back, okay, you have to kneel close to the patient's chest to start with your proper body mechanics. Okay, all right. Now, after kneeling close to the patient's chest, okay, you have to use one of your hands or the heel, okay, of your hand, okay, and position on the center of the chest, okay. All right. To approximate, okay, the center of the chest, your middle finger must be at the level of the nipple line, okay. But of course, it will not be applicable to all patients because there are patients who are Susan, okay, who are Dolor, okay. I think you know all about it. All right, so after placing the heel of your hand on the center of the chest, okay, you have to use the other hand to place on the top of the other, like this one. You can interlace your finger. You can interlace your fingers to support, okay, your chest compression, okay. Then you have to lean forward, okay, as you can see in the video, right, and straighten your arms, lock your elbow, okay, and you have to be stable, okay, before you perform the other components of high quality chest compression, like compressing the proper depth, and applying the rate of compression, which is 100 to 120 compressions per minute, and considering the chest recoil and minimizing the interruption, okay. All right, if you do not, if you disregard kneeling, the kneeling principle, okay, it will be very hard for you to give your compression. Is imagine yourself standing beside a patient, okay. How would you do the compression properly? Okay, well, it's um I don't know how to think of it, okay. All right, then that's the thought. You have to follow that. You have to raise, that tone in order for you to okay, I think I'm lagging. All right, anyways, once you begin your compression, okay, you have to complete it up to the 30th compression, okay. That is the principle of minimizing the interruption. All right, now the principle of compressing too fast, or the faster the better, is not anymore applicable in 2015 and 2020 guidelines, because we have this spacing that I have shown to you, okay, a while back, okay, that is as if you are marching, okay, in a relaxed manner, okay, right. Now let's take a look at the child chest compression, okay. You have to take note of the
In this practice, you will perform chest compressions by following along with the video demonstration. Each person should have a mannequin. You will do 2 sets of 30 compressions. If you need more practice when it ends, run the segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1.
okay. So can someone tell me the difference of the way we do the chest compression to adult and that of the children? Anyone? Have you noticed a difference regarding the way we do chest compression in children and in adult? Okay, from Catherine. From Catherine, adult using both hands, okay. Child use one hand. Yes, okay. All right, we use only one hand for chest compression for children from Marie Arianet, and from Canceron Dianara, adult both hands interlock. Okay, Regina, adult two hands, child one hand. Yes, okay. All right, so that those are correct. Okay, the reason, okay, why we have to apply, okay, the one hand technique for children is to to minimize the force of compression. Okay, it lessen the force of compression. Okay, since in children, okay, their weight, okay, is much lesser than the weight of the adult. We need to lessen the weight and the force, okay, that we have to apply. Okay, and that can be attained, okay, if we use just one hand technique. All right, any clarification regarding that? Okay, thank you for your responses. Okay, it means a lot to me. Okay, now let's take a look at the how we compress the chest.
In this practice, you will perform chest compressions by following along with the video demonstration. Each person should have a mannequin. You will do 2 sets of 30 compressions. If you need more practice when it ends, run the segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1.
All right, of course, okay, what we can notice about how we perform the chest compression in infants is the same with the child. Okay, we need to change the use, okay, of our hands, okay, in order for us to lessen the force and weight, okay, that we apply, okay, to the infants. Okay, we use the finger technique, okay, in infants. Okay, it's either your index and the middle finger, and or the middle finger and the ring finger. All right. Okay, now the center of the chest, okay, for infants should always be just below the nipple line. Okay, no exemption. Okay, all right, because we do not have a variation with regard to the sizes of the breast or the chest of the infants. Okay, it should always be below the nipple line. All right. Okay, any more question regarding okay, the chest compression, because we need to play the rescue breathing. Any more question or clarification? All right, okay. If not, okay, let's discuss the rescue.
Rescue breaths are artificial breaths given to someone who is not breathing. They are given by blowing air into the mouth to inflate the lungs. The air you breathe contains about 21% oxygen. Your exhaled air still contains between 16% and 17% oxygen. This exhaled oxygen is enough to support someone's life. To give rescue breaths, you need to make sure there is an open airway. The airway is the only path for getting air into the lungs. An unresponsive person can lose muscle tone. If flat on his or her back, the base of the tongue can relax and obstruct the airway. This is the most common cause of a blocked airway. The tongue is attached to the lower jaw. Lifting the jaw forward pulls the tongue away from the back of the throat and opens the airway. You can open a person's airway by using the head tilt chin lift technique. Place one hand on the forehead. Place the fingertips of your other hand under the bony part of the chin. Apply firm backward pressure on the forehead while lifting the chin upward. This will tilt the head back and move the jaw forward. Maintain the head tilt with your hand on the forehead. Leave the mouth slightly open. Avoid pressing into the soft tissue of the chin with your fingers, as this can also obstruct the airway. Even though the risk is very low, as a BLS provider, use a protective barrier such as a CPR mask when giving rescue breaths to minimize your exposure to infectious disease. Before using a CPR mask, quickly inspect it to make sure the one-way valve is in place. Place the mask flat on the person's face with the top of it over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom. Tilt the head and lift the chin to open the airway. Lift the face up into the mask to create an airtight seal. Blow through the valve opening to deliver breaths. Each breath should be about 1 second in length and have only enough air to create a visible rise of the chest, but no more. Additional air is unnecessary. Remove your mouth and let the person exhale completely after each breath. Take a fresh breath between delivering breaths. If you remove your hands from the head, the airway will close again. It is necessary to open the airway each time you give rescue breaths. Rescue breaths for children and infants are performed in the same manner as for adults. It is recommended to use an appropriately sized pediatric CPR mask. The airway of an infant may become blocked if the head is tilted too far. Position an infant's head in a neutral position, in which the ear openings are level with the infant's shoulders. Special care should be taken not to give too much air in a single breath. Provide only enough air to make the chest visibly rise, but no more. The jaw thrust is a convenient airway technique, especially when working in a team or when using a bag mask device. Position yourself above the head of the person. Place the mask flat on the person's face with the top of it over the bridge of the nose. Place your thumbs and heels of your hands along the sides of the mask to seal the mask against the face. Hook your index fingers under the angles of the jaw just below the ears. Lift and tilt the head backwards. Use counter pressure against the cheeks and displace the jaw and move it upward and into the mask. This will open the airway. Blow through the valve opening to deliver breaths. Each breath should be about 1 second in length and have only enough air to create a visible rise of the chest, but no more. A bag mask device allows rescuers to provide rescue breaths without having to blow into a person's mouth. It can also deliver high concentrations of oxygen when connected to an oxygen delivery system. A bag mask can be used by a single BLS provider, but is best used by two. From above the head, place the mask flat on the person's face with the top over the bridge of the nose and use the jaw thrust airway technique to establish an open airway. Have a second BLS provider squeeze the bag with both hands to ventilate. Squeeze the bag slowly enough to deliver each breath over 1 second. Make the chest visibly rise, but no more. When using a bag mask as a single provider, position yourself above the person's head. Place the mask flat on the person's face with the top over the bridge of the nose. Use the thumb and index finger of one hand around the valve in a C position to seal the mask against the face. Use your remaining 3 fingers in an E position under the bony part of the chin. Tilt the head back and lift the jaw up and into the mask to open the airway. Use your free hand to squeeze the bag and deliver the rescue breaths. Deliver each breath over 1 second. Make the chest visibly rise, but no more. Bag mask rescue breaths for children or infants are done in the same manner as an adult. It is recommended that an appropriately sized pediatric bag mask be used. When caring for someone who is seriously injured, establishing an open airway is a higher priority than protecting a possible injury to the spine. Without a patent airway, a person will not survive regardless of injury. When the potential for a neck injury exists, a jaw thrust without head tilt can be used to open the airway. Position yourself above the head of the person. Place the mask flat on the person's face with the top of it over the bridge of the nose. Place your thumbs and heels of your hands along the sides of the mask to seal the mask against the face. Hook your index fingers under the angles of the jaw just below the ears. Use counter pressure against the cheeks to displace the jaw and move it upward and into the mask without tilting the head. If you find the jaw thrust without head tilt does not open the airway, use jaw thrust with head tilt or the head tilt chin lift technique instead, even if neck injury is suspected. You must establish an airway for a person to survive.
Okay, so that's how we do the rescue breathing. Okay, the use of the bag mask will be further discussed in advanced cardiac life support because it's not part of the basic life support. All right, the only thing that is important in the rescue breathing or the ventilation is you need to open the airway of the patient. Okay, you always assume that there is a blocked airway if the patient is lying supine, because the back of the tongue will serve as the blockage if the patient is lying supine. Okay, so you need to consider the different maneuvers or technique, such as the head tilt chin lift, okay, the jaw thrust without head tilt, and the jaw thrust with head tilt. All right, but the head tilt chin lift is the most common that we use if you are a single rescuer. All right. Okay. If you are multiple rescuer, which will be discussed in that topic later on, okay, you need to use the jaw thrust, okay, with or without head tilt technique. All right. Okay. Now I have a question. Oh, I forgot my question. Later, I forgot my question. All right, I suddenly forgot it. Okay. Again, no, okay, if you do not want to do the rescue breathing barely, or the modern resuscitation, it's still appropriate to decide no, okay, or you might use the barrier devices. Okay, right. Again, if you are in the hospital, okay, you have to use the bag mask ventilation, okay, and avoiding the use of the mouth to valve mask ventilation, okay, or resuscitation. All right. I'm still remembering my question. Okay, now this is the question. It's true that the jaw thrust without head tilt chin lift or the jaw thrust without hyperextension of the neck is applicable to trauma patients, okay, where there is a concentration uh, of cervical spine injury, okay. But what if, for example, there is a spine injury or cervical spine injury secondary to trauma, okay, and you are using the or performing the head tilt chin lift, okay. All right. Of course you need to switch to jaw thrust, okay, without head tilt chin lift, okay. But okay, you notice that there is no rise and fall of the chest for each introduction of air, okay, in the rescue breathing, okay, right, using the jaw thrust without head tilt, okay. So what will be your consideration? Again, now you are caring for a patient with trauma, specifically cervical spine injury. So you have to use or you have to do the jaw thrust without head tilt technique. Okay, but suddenly, okay, you notice that the chest is not rising. Okay, with each introduction of air. Okay, what is your consideration? Of course, you need to observe a rise and fall of the chest. Okay, but how would you do that? Okay, so according to Regina, use jaw thrust with head tilt. Yes, okay, because oh, wait a minute, guys. Yes, okay, from Regina. Okay, I'm sorry, I have to do something. Okay, always remember that the airway breathing is more important, okay, than any other consideration. Okay, even if the previously considered case is cervical spine injury. Okay, you have to do the jaw thrust with head tilt instead. Okay. All right. Any question? Okay, so another thing or another principle that I would like to highlight, okay, in the rescue breathing is the way, okay, we give the air. Okay, it must be 1 second in length. Okay, it's not like this. Okay, it's not like that. Okay, it must be okay, and it's considered to be 1 second. 1 second in length. Okay, and just enough, okay, for a rescuer or for a provider to inhale regularly. Okay, just like how would you inhale normally? Okay, do not inhale too much of air, okay, because it's it can contribute to exhaustion. Okay, you might get tired easily. All right. Okay. Okay. The consideration, okay, for the rescue breathing in children and infants is, of course, the only consideration is you just have to lessen, okay, the introduction of too much air, okay, as you would, okay, in adult. Okay, the technique to approximate the appropriate volume of air, okay, to be introduced is when there is a rise and fall of the chest. Even a minimal chest rise will do. Okay, clear? Any question? Any question? Okay, so I will be playing the mouth-to-mouth resuscitation through valve mask, okay, for the 3 age groups.
In this practice, you will perform rescue breaths by following along with the video demonstration. Each person should have a mannequin and a CPR mask with a personal one-way valve or mouthpiece. You will do 5 rescue breaths. taking about 3 to 5 seconds between each breath. If you need more practice when it ends, run this segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1.
Breathe. 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 Breathe.
In this practice, you will perform rescue breaths by following along with the video demonstration. Each person should have a mannequin and a CPR mask with a personal one-way valve or mouthpiece. You will do 5 rescue breaths, taking about 3 to 5 seconds between each breath. If you need more practice when it ends, run this segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1.
Breathe. 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 Breathe.
In this practice, you will perform rescue breaths by following along with the video demonstration. Each person should have a mannequin and a CPR mask with a personal one-way valve or mouthpiece. You will do 5 rescue breaths, taking about 3 to 5 seconds between each breath. If you need more practice when it ends, run this segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1.
Breathe. 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 Breathe.
All right, so that's how we do the rescue breathing in all age groups, okay, using the valve mask. Okay, again, the use of the bag mask, okay, the amber bag, okay, will be tomorrow, okay, in advanced cardiac life support. Okay, any question regarding the rescue breathing? Okay, oh, I would just like to add the interval, okay, between each rescue breathing. Okay, all right, the standard is every well, if you are just a single rescuer and you're alone, okay, doing the CPR, okay, the interval between each rescue breathing, okay, must be every 3 to 5 seconds, okay, but it depends, okay, on the scenario. Okay, later on we will further discuss all about that interval. Okay, all right. Okay, so the next discussion or the next topic, it would be the automated external defibrillation. Okay, all right, followed by the basic life support assessment.
Mrs. Williamson collapsed in the treatment room. Activate EMS.
Remove clothes from patient's chest. Peel white pads from gray plastic case. Attach pads to bare skin exactly as shown. Stay clear of patient. Analyzing heart rhythm. Shock advised. Stay clear of patient. Press the flashing orange button now. Shock delivered.
Begin CPR.
AEDs are designed to be simple to operate. Voice instructions, lights, and screen prompts guide an operator through use. There are many different brands of AEDs, but the same basic steps for operation apply to all. Opening the lid will turn on the power for some AEDs. With others, simply press the power button. This starts voice instructions and readies the device for use.
Apply pads to patient's bare chest.
Pads must be applied to a bare chest. If needed, quickly tear away or use scissors to remove all clothing from the torso. Dry the chest quickly if wet. For a woman, remove the bra to provide better access for pad placement. Locate and pull out the defibrillation pads. The pads have pictures on them to show proper placement. Peel the pads from the backing sheet one at a time and place each as shown in the pictures. Place one pad below the right collarbone above the nipple and beside the breastbone. Make sure it adheres well by pressing it flat. Place the other pad lower on the left side over the ribs and a few inches below the armpit. Again, press firmly. Most AEDs automatically start analyzing once the pads are in place.
Analyzing.
Stop CPR. Movement can interrupt the analysis. Be certain that no one is touching the person. If defibrillation is advised, the AED will begin to charge for shock delivery.
Shock advised. Stay clear of patient. Deliver shock now.
Quickly look to make sure no one, including you, is in contact with the person before delivering the shock. For most AEDs, a button is pressed to deliver the shock.
Delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions. In cases when a shock is not indicated by the AED,
No shock advised.
immediately resume CPR. AEDs are also designed to detect problems during use and guide you through corrective actions.
Press pads firmly to patient's bare skin.
If a troubleshooting message occurs at any time,
Insert connector firmly.
stay calm and follow the AED's voice instructions. Cardiac arrests involving children are likely caused by the initial loss of the airway or breathing. High-quality CPR with effective rescue breaths may be the only treatment required for successful resuscitation. However, conditions can occur for which defibrillation of a child or infant is warranted. The steps for using an AED on a child or infant are similar to an adult. Most AEDs have specially designed pads or mechanisms available that reduce the defibrillation energy to a level more appropriate for a smaller body size. For smaller children and infants, place one pad on the center of the chest just below the collarbones. Attach a second pad on the center of the back between the shoulder blades. Follow the AED's voice instructions to provide the appropriate care.
All right. Okay, we have different we have a lot of brands, okay, of AEDs. Okay, we have Philips, we have Zoll, we have Nokia, we have Samsung. No joke. Okay, no, we didn't have a Nokia. Okay, but Samsung, yes. Okay, we do have an AED. Okay, all right. But I just like to give you the standard way or steps on how to operate the AED. Okay, the most important thing is you open. Okay, you know how to open. Okay, or turn the AED on. Okay, because in some AEDs, opening the lid, okay, will make the AED on. Okay, while in others, okay, you have to look for the green button, okay, with an on and off icon, okay, to turn the AED on. Okay, that is the most and the first thing to do, or the most important thing to do, okay, in operating the AED. Because right after you turn on the machine, okay, the AED would tell you what to do. Okay, there are instructions, okay, that you need to follow. Okay, for example, the AED says do not touch the patient. Okay, then you must not touch the patient. All right. Okay, that is when the AED is about to analyze the rhythm, okay, because touching the patient may compromise, okay, the reading, okay, or analysis of the AED. All right, when the AED says attach the pads, okay, you have to attach it, okay, all right, because the AED would only analyze, okay, if you already attached, okay, the pads. Okay, now speaking of the attachments of the pads, okay, the specific locations of the pads, okay, the right pad, okay, must be located below the right collarbone beside the sternum. Okay, so if this is our breastbone and this is our collarbone, okay, it must be here. Okay, and the left pad, okay, must be positioned, okay, lower on the left, okay, that is few inches below the armpit. Okay, so what we do is we place our hand under the armpit of the patient and right after the small finger, okay, that is the location of the left pad. Okay, all right, so the heart must be sandwiched by the two pads. Okay, that is the principle of the location. Okay, all right, so you might not want to attach the pads lower, okay, than usual, okay, or lower than the recommended position or location. It's not going to be effective, okay, because the heart may not be at the center of both pads. Okay, all right, so usually, okay, once you turn the machine on, okay, the AED would say remove clothing, okay, from the patient's chest. Okay, all right, that is because you have to expose the chest, okay, in order for you to attach the pads, right? Then right after that, okay, the patient would the AED would instruct you to attach the pads. Okay, then after you attach the pads, the AED will start to analyze. Okay, the AED would say, do not touch the patient, analyzing rhythm. All right, once the AED says do not touch the patient, analyzing rhythm, okay, you, okay, who is operating the AED must aware, okay, your teammates not to touch the patient. All right, okay, when the AED analyzed a ventricular fibrillation, it would automatically charge itself. Okay, but again, okay, the AED will instruct you not to touch the patient. Okay, and it will be charged. Okay, all right, right after the charging, okay, you can see a blinking button. Okay, that is the shock button. And the AED would tell you, do not touch the patient, push the shock button. Okay, clear? All right, but before you push the shock button, make sure you you have to see it that no one is touching the patient. Okay, so you have to count 1 to 3. Okay, or you would say like this. Okay, do not touch the patient. Okay, or I'm clear. Are you clear? Do not touch the patient. I'm clear. Are you clear? Right? If your teammate acknowledge, okay, then you have to say, I'm shocking on 3, 1, 2, and on the third count, okay, you have to push. That's the only time that you can push the shock button. All right. Any question? Okay, there is no complicated principle, okay, on how to operate the machine. Okay, it's just the technique is you just have to open the machine, or you just have to turn the machine on in order for you to know, okay, the instruction, okay, of the AED. All right. Okay, now if you ask me, okay, when to use the AED, okay, right? Once the AED is available, okay, you have to use it. Okay, there's no perfect timing, okay, of the use of the AED. Okay, once the AED is available, okay, someone brought an AED to the scene, okay, you have to operate the AED. Okay, can we use the AED in infants and children? Yes. Okay, all right. If there is an available AED beside the patient or beside the children or beside a child or infant, you have to still attach the pads on specific locations, and you have to wait for the analysis of the AED. All right, okay, but make sure, okay, you follow the instruction of the pads, okay, in infants and children. Okay, the location of the pads in infants and children, okay, must be anterior and posterior. Okay, so one of the pads must be placed anteriorly, okay, and other pads must be positioned at the back, okay, um, um, in between the shoulder blades. All right. Do you have to use AED twice, or can we use the AED twice? Yes. Okay, we can use. Well, actually, okay, if let's say, for example, the first shock, okay, is already delivered, okay, we should not remove the pads, okay, because every 2 minutes the AED will reanalyze again, okay. All right, that is standard in all kinds or in all brands of AED, okay. So we have to retain the pads until the advanced EMS personnel arrive, okay. All right, I will actually, they will not remove it until the patient is moved to a stretcher or a gurney, okay, inside the ambulance, right? Because in ambulance, okay, they will use another AED, okay, that they own. All right. Okay, that is a question, okay, from Carla. Okay, thank you. All right, any more question? Yeah, before we take our second break, because it's already 10:11. Question? Am I being too fast? Okay, please you can butt me in, you can inform me. Okay. Any question? Nah. Okay, so if there's no question, okay, I will give you 10-minute break. Okay, my time is 10:12. We will be resuming at 10:22. Okay. All right, see you after 10 minutes. And we're back. Okay, now we're going to be discussing the BLS assessment. Okay, the BLS assessment is also called the primary assessment, okay, or primary survey in the basic life support. The secondary survey or the assessment, okay, is under or a part of the advanced cardiac life support. Okay, but before we play the video, can someone give his or her insight regarding how we assess the patient? Okay, let's say, for example, okay, we made the scene clear, and we are now approaching the patient. Okay, so how would you assess the patient this time? Anyone? How would you assess the patient? Okay, so what are these steps on doing the assessment? Hello, are you there? The primary assessment, or the steps on doing the primary assessment is the same, okay, to both out of hospital and in hospital. Okay, yes, okay, from Claricel, we shake the person, tap their shoulders. Okay, all right. What about the others? Yes, okay, very good. Okay, we have to shake the person. Yes, assess for breathing and pulse. Yes, okay. What else? Okay, that is from A's J. Okay, check the scene safety. Yes, okay, that is the first thing to do. All right. Okay, so thank you so much. Okay. All right. Check patient responsiveness. Yes, okay, that is a bit tapping the shoulder of the patient. Okay. All right. There has been a change. Okay. With the assessment. Okay. From 2015. Okay, from 2000 year 2000 2010, okay, and 2015. Okay, all right. In 2010, okay, the way we assess the patient is we check the response, okay, we check the breathing, and we check the pulse. Okay, but in 2015 and 2020, okay, we have to simultaneously check, okay, the breathing and the pulse. Okay, it means that while you are obtaining if there is a pulse, okay, you have to observe for the rise and fall of the chest. All right. Okay, now let's take a look at the video.
The BLS assessment is a simple way to quickly identify if resuscitation is required. It is the same for all ages and is performed quickly. Before anything else, pause and assess the scene for hazards. Take standard precautions to prevent contact with blood or other potentially infectious materials. If it is safe, check for responsiveness. Tap or squeeze the person's shoulder and ask loudly, "Are you all right?" For an infant, tap the foot. If unresponsive, quickly look for signs of normal breathing. At the same time, check the carotid pulse in the neck. Normal breathing is effortless, quiet, and regular. Weak, irregular gasping, snorting, or gurgling sounds, known as agonal breaths, can occur early in cardiac arrest. These actions provide no usable oxygen. This is not normal breathing. For an adult, check the carotid pulse in the neck. Locate the bony Adam's apple with your fingers, slide them into the groove between the windpipe and the muscle on the side of the neck closest to you. For a child, check the carotid pulse or the femoral pulse in the leg. Place your fingers just below the middle of the crease where the leg and torso meet. For infants, feel the brachial pulse on the inside of the upper arm. Lay your fingers across the arm and compress inward. Take at least 5 but no longer than 10 seconds to assess breathing and pulse. If you are unsure, assume they are absent. If not already being done, tell another person to activate the protocol and get an AED. Relay what you have found so it can be passed on. Your assessment of the person and situation will determine the care you provide. If the person is breathing normally and uninjured, place her in a side-lying recovery position. Place the arm nearest you up alongside the head. Bring the far arm across the chest and place the back of the hand against the cheek. Grasp the far leg just above the knee and pull it up so the foot is flat on the ground. Grasping the shoulder and hip, roll the person toward you in a single motion, keeping the head, shoulders, and body from twisting. Make sure the head ends up resting on the extended arm. Roll far enough for the face to be angled towards the ground. Make sure there is no pressure on the chest that might restrict breathing. The recovery position helps protect the airway by using gravity to drain fluids from the mouth and keep the tongue from blocking the airway. Frequently assess and monitor the person's breathing. The condition can quickly become worse and require additional care. If the person is not breathing or only gasping, but definitely has a pulse, he is in respiratory arrest. The indicated care is rescue breathing, which is ongoing rescue breaths provided without chest compressions. If the person is not breathing or only gasping and does not have a pulse, he is in cardiac arrest. The indicated care is CPR, a repeating combination of chest compressions and rescue breaths. Always perform a BLS assessment to quickly determine the need for CPR. Ensure the scene is safe. Assess responsiveness. Assess for breathing and pulse. Activate the emergency response protocol for your setting and get an AED.
All right, so those are the steps on how to assess the patient. Again, you have to start at the scene. If the scene is safe with hazards, okay, you need to tap the shoulders and ask loudly, "Hey, are you okay?" Okay, but in real life, okay, whatever your technique would be appropriate. Okay, for an infant, okay, you have to consider the food. Okay. All right, then after the response check, you need to locate the carotid pulse, okay, in adult. Okay, And while checking for the pulse, you need to observe for the rise and fall of the chest. Okay, that must be no more than 10 seconds. Okay, so you are allowed to check for the breathing and pulse, okay, for no more than 10 seconds. Okay, 7 to 8 seconds will do. Okay, all right, because we need to recognize the presence of cardiac arrest immediately. Okay, so that we can provide the CPR if ever the patient is under cardiac arrest. All right. After checking for the pulse and breathing, okay, you need to activate EMS, okay, if you are out of hospital scenario. And if you are in the in-hospital scenario, you need to activate the emergency response protocol, which is the code blue. Okay, again, you need to be familiar with the way you on how you can call the code blue in your facility. All right. Okay. The steps, okay, and checking or recognizing the presence of cardiac arrest in adult is the same way with that of the children and infants. All right. Okay. Now, after taking the primary survey, okay, you can obtain 3 cases. Okay, the first case is if the patient is just unresponsive, but the patient has a breathing and a pulse. Okay, that is the first step. Okay, and the indicated care is the recovery position or the sideline recovery position that is applicable. Okay, in the out of hospital scenario. Okay, but if you are in hospital scenario, okay, you need to raise the upper part of the bed, okay, into high Fowler's or semi Fowler's position. Okay, no sideline position in the in-hospital scenario. All right. Okay. Now, after you call for help, okay, you have to return to the patient. Whatever the way you called for help, you have to return to the patient and provide the indicated care. All right. Now, okay, if the patient is unresponsive, no breathing, but definitely has a pulse, okay, the patient is under respiratory arrest. Okay, the only thing that you need to do is the rescue breathing. Okay, later on we will be discussing the principles, okay, of the rescue breathing. But if the patient, okay, is unresponsive, no breathing, no pulse, that is the third case. Okay, that is the time that you provide the combination of the rescue breathing and the chest compression, which is the CPR or the cardiopulmonary resuscitation. Okay, any question? Any question? Before we proceed to the video presentation of the caring for the patient in respiratory arrest. Any question? Okay.
Heather? Heather? Heather, breathe! Heather! Heather, breathe, please!
What's going on here?
I think she overdosed. She took something new.
Okay, let me check. Ma'am, can you hear me? Ma'am, can you hear me?
A person in respiratory arrest has stopped breathing but still has a beating heart.
Dispatch, P37, can you advise EMS? This is a possible overdose. She's not breathing but has a carotid pulse. I'm gonna start rescue breathing.
Copy P37, possible overdose, rescue breathing in progress.
Without immediate intervention, respiratory arrest can quickly progress to cardiac arrest.
James, I've got my naloxone kit.
Great, go ahead and give it. I'm gonna keep giving rescue breaths.
Okay, James, I'm ready.
Okay, after my next breath.
Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check for signs of normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to assess. This person is unresponsive, not breathing, and has an obvious pulse. Have someone activate your emergency response protocol and get an AED if one is available. Establish an airway and give a rescue breath. Continue to provide one high-quality rescue breath every 5 to 6 seconds, or about 10 to 12 breaths per minute. Reassess the pulse about every 2 minutes. Take no longer than 10 seconds to do so. If the pulse is absent and tissue signs indicate poor perfusion, or you are unsure, perform CPR starting with compressions. If an opioid overdose is suspected, consider the use of naloxone, as indicated by your local protocols. The rate of rescue breaths when performing rescue breathing for children and infants is 1 breath every 3 to 5 seconds, or about 12 to 20 breaths per minute. When monitoring the pulse of an infant, check for the brachial pulse in the arm. Add compressions and perform CPR on a child or infant if the pulse rate is 60 beats per minute or fewer, and it appears the heart is too weak to adequately move blood forward. Signs of poor blood perfusion include pale, mottled, or bluish skin color, weak pulse, and cool extremity temperature.
All right, so if the patient is under a respiratory arrest, the patient is not breathing, okay, but has a pulse, okay, you have to provide 2 minutes of rescue breathing. All right, okay, and the again, you have to consider the principles and how to give an effective rescue breathing, okay, and that is an introduction of air that is enough for the chest to rise and fall, okay, and with each regular introduction of air, right? Okay, for the adult, okay, you need to provide an interval of 5 to 6 seconds for each rescue breathing, and for the children and infants, you need to give an interval of 3 to 5 seconds for each rescue breathing. Okay. Okay. Now, after 2 minutes of the rescue breathing, you have to check again for the pulse and breathing, okay, because sometimes, okay, it will progress to cardiac arrest, okay, so you need to change your management to CPR, or the patient regains spontaneous breathing, so you just need to place the patient recovery position, okay, if the patient is still unresponsive with breathing and with pulse. Okay, all right, any question? Any question? Okay, none. Okay, from Julius Bernard. All right. Okay, maybe we let's take a look at the video of caring for cardiac.
Take over for you.
How long has he been down?
Just a few minutes.
Sir, are you all right? One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21.
Stay clear of patient. Analyzing. Shock advised.
Everybody clear?
Stay clear of patient. Deliver shock now. Shock delivered.
1, 2, 3.
Immediate high-quality CPR and defibrillation with an AED can double or even triple the chance for survival from sudden cardiac arrest. Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check for signs of normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This person is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Use the AED immediately when it arrives. Turn on the AED and adhere the defibrillation pads to the bare chest. Allow the AED to analyze the heart.
Analyzing.
If a shock is advised,
Shock advised. Stay clear
make
of
sure
patient.
you are not touching the person before delivering the
Deliver
shock.
shock now. Shock delivered.
Immediately after a shock is delivered, resume CPR, starting with compressions. Voice instructions and additional analysis by the AED will guide you through further care. Don't stop until the person shows signs of life, another BLS provider takes over, or you are too exhausted to continue.
Hold up, stop CPR. Who's responding?
If a person begins to breathe, moves, or respond, stop CPR and place the person in the recovery position. Leave the AED turned on and the pads attached in case cardiac arrest reoccurs. In cases where a shock is not indicated by the AED,
No shock advised.
immediately resume CPR. Continue to follow the AED's instructions. Compression-only CPR is being widely promoted to people who are not trained in CPR in order to encourage and increase the chance for bystander care. Simple instructions in compression-only CPR are being shared through things such as social media and public service announcements. EMS dispatchers are also providing compression-only instructions during emergency calls. However, compression-only CPR is a limited approach to treating cardiac arrest. At some point, rescue breaths are essential for all cardiac arrests, especially for secondary cardiac arrest. As a trained BLS provider, perform both compressions and breaths during CPR. Most arrests involving children are secondary to the initial loss of an airway or breathing. Immediate CPR with an emphasis on effective rescue breaths may provide the only chance for survival. Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check signs for normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This child is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise, but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Use an AED immediately if one arrives. Don't stop until the child shows signs of life, another BLS provider takes over, or you are too exhausted to continue. Infant CPR is similar to adult and child CPR. Pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check signs for normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This infant is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise, but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Don't stop until the infant shows signs of life, another BLS provider takes over, or you are too exhausted to continue.
Okay, to perform the management in a patient under cardiac arrest, you need to provide 5 cycles of CPR. It means you need to give 30 compressions followed by 2 rescue breathings, for 5 times. That is 5 cycles. And remember that the 5 cycles of CPR is equivalent to 2 minutes. All right. So if the AED is in place, the AED would reanalyze again after 2 minutes. That is equivalent to 5 cycles of CPR. All right. Yeah, it's designed for that. All right. The caring for patient under cardiac arrest is similar to that in adult, is similar to that of the children and infant. All right. Though there are changes in the principles if we are, or if you become multiple rescuers, because we are just talking about a single rescuer. For a single rescuer, you provide primary assessment, then you give CPR on your own, 5 cycles of CPR, and you check for the pulse and breathing on your own, but if you are already 2 rescuers or multiple rescuers, of course, there is or the principles may be or may change, according to how we provide the management in a multiple rescuer. Any question? Any question regarding the CPR? Any noticeable concern that you want to clarify, or the principles that you want to clarify? Before we proceed to another, or to the next video. Any question? Okay. All right. Let's go back to the other page where, wait. Okay, just give me a sec. Okay, right.
And punch it out now, all the way in front. If you want a little bit more intensity, push to the palm. Keep those hands in the water. Now push, push. Lift up those knees, get those shoulders down and back. Let's go. Good job. Take it to the side. Same thing. Fist is a little bit easier. Palms a little bit harder. Get those knees up. Up that floor. Let's go. Let's go.
high-performance CPR not only requires high-quality CPR skills, but it also relies on the efficiency of multiple providers working as a team. It is common for multiple providers to respond to a cardiac arrest, but a resuscitation may start with a single provider. Other providers can be integrated as they arrive. When two providers are available to perform CPR, one performs chest compressions, while the other gives rescue breaths. For adults, the ratio remains at 30 compressions and 2 rescue breaths. The compressor pauses to allow rescue breaths to be given. Give breaths as quickly as possible to minimize the interruption. High-quality compressions are tiring. If an AED is not attached, switch every 2 minutes at the end of a CPR cycle. Clearly communicate the details of the switch ahead of time to prevent confusion. If a third provider is available, have him or her relieve the compressor while rescue breaths are being given to shorten the interruption. With 2 providers, use a 15:2 ratio of compressions and breaths for a child or infant. When 2 or more BLS providers respond in an emergency, orchestrating actions is necessary for high-performance resuscitation.
Yes. Our lifeguards are responding now.
Stay clear of patient. Analyzing. Stay clear of patient. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered.
It is important to recognize the common roles identified for a team resuscitation and be ready to assume any one of them. The compressor is typically the initial responding provider. A BLS assessment is done and CPR is started, beginning with compressions. When a second person is available, he becomes the ventilator and takes responsibility for maintaining an airway and giving rescue breaths. An AED operator brings and quickly attaches defibrillation pads without interrupting CPR. This person is also responsible for the efficient and safe delivery of defibrillation shocks.
1, 2, 3, 4, 5, 6, 7, 8, 9, 30. 1, 2, 3, 4.
Yes, I hear the sirens. Oh, they're here.
Stop CPR. Stay clear of patient. Analyzing. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered.
1, 2,
Begin
3,
CPR.
4, 5, 6, 7, 8, 9.
The team leader takes a general perspective to supervise and improve overall team performance.
What's the story? He was exercising in the water and then he collapsed. How long since you started?
Effective team communication is essential. Speak calmly and in simple terms.
2 to 3 minutes. Was it witness? Yes.
This person is also the main point of internal and external communication. If you are asked to do something, repeat it back to confirm and reinforce the instructions.
Back mask and O2 ready?
Other roles may be filled as necessary. A second ventilator to help with the use of bag mask, or a scribe or reporter to document patient information, treatments, and intervention times. In the transition to more advanced care, additional roles for actions such as administering medications may be added. When an AED is attached, plan to relieve the compressor during the time an AED analyzes the heart. This typically occurs every 2 minutes.
Are you guys clear? Clear.
After a shock is delivered or no shock is indicated, the new compressor immediately resumes CPR, starting with compressions. After a resuscitation, A facilitated group discussion or debriefing lets team members reflect on the care provided. Debriefing identifies issues with skills, equipment, or established procedures. It also emphasizes and reinforces what was done well. Changes based on debriefing can improve the overall standard of care for future resuscitations. Using realistic, scenario-based practices is an excellent way to prepare for team-based resuscitations. Practice using a team approach. An advanced airway device may be inserted into the throat during a resuscitation to maintain an open airway. When an advanced airway device is in place, the mask from the bag mask is removed and the bag is attached directly to the device to ventilate. As with other approaches to rescue breaths, provide enough air to make the chest visibly rise. Once an advanced airway device is in place, it is no longer necessary to pause compressions to give breaths. Provide continuous compressions at a rate of 100 to 120 per minute. Regardless of age, provide a single breath every 6 seconds or 10 times a minute.
Okay, for the consideration of multiple rescuers approach, okay, it is very important for you to have a reserve team member. Okay, for example, okay, you are two providers. Okay, one will be performing the chest compression, while the other, okay, will be responsible for the ventilation. Okay, and make sure you switch, okay, right every after 2 minutes or 5 cycles of CPR. Okay, so the provider who was doing the chest compression, okay, must be switched, okay, with the other one, okay, who was doing the ventilation, okay, because chest compression is more tiring or exhausting, okay, than doing the ventilation. Okay, if you are 3 rescuers, okay, the 3 of you should surround the patient, okay, the 2 on both sides, and the other one, okay, will be providing the ventilation. Okay, but of course, there should only be one, okay, who will take responsibility of chest compression. Okay, but since there is someone at the other side, okay, right after the chest compression, okay, of the previously doing the compression, okay, must be switched with that of the provider on the other side. Okay, if you're 4 rescuers, then of course, okay, the other one, okay, should be behind, okay, the other, okay, because we do not have any more place, okay, around the patient. Okay, there must be only be 3 providers, okay, around the patient. All right. Okay. Okay, now for the concentration in infants and children, okay, if you are a single rescuer, okay, you need to provide a 30 compression to 2 rescue breathing for 5 cycles. Okay, but if now in multiple rescuers, okay, it's the same. Okay, but for infants and adults, okay, if you are already multiple rescuers, okay, you need to switch to 15:2 principle. Okay, 15:2 principle for children and infants. Okay, another consideration for the infants, okay, if you are 2 rescuers, okay, you have to switch your compression technique, okay, from finger technique, okay, to the encircling hand technique. Okay, encircling hand technique is like this. Okay, you hold the chest of the infant like this, okay, around, okay, the chest, okay, while using the thumb, okay, for the chest compression. Okay, while the other one, okay, of course, okay, should be above the or should be positioned above the patient's head, okay, to perform the ventilation. All right, any question regarding the multiple approach, okay, for the cardiac arrest? Of course, we are dealing with basic life support. Okay, it would change. It will be changed. Okay, the principle will be changed in the advanced cardiac life support. Yes. Any question? Okay, none. Okay, so if there's no question, okay, we are down to the last topic, okay, which is the foreign body area obstruction, or FBOB, or simply the choking.
Choking can occur when a solid object, such as a piece of food or a small object, enters a narrowed part of the airway and becomes stuck. On inhalation, the object can be drawn tighter into the airway and block air from entering the lungs. A forceful thrust beneath the ribs and up into the diaphragm can pressurize the air in the chest and pop an obstruction out of the airway. Compression of the chest over the breastbone can also create enough pressure to expel an object. To provide the appropriate care, you must first be able to recognize the difference between a mild blockage and a severe blockage. With a mild blockage, a person can speak, cough, or gag. This type of blockage is typically cleared by the affected person naturally through forceful coughing. Allow someone with a mild blockage to try and resolve the problem on his own. Stay close and be ready to take action if things worsen.
Morning, Chrissy. How are you feeling?
Much better, thank you.
Good. I need to get another set of your vital signs after you finish your breakfast.
Sure.
When a severe blockage occurs, a person cannot take in enough air to dislodge the object. Signs of severe obstruction include very little or no air exchange, the lack of sound, and the inability to speak or cough forcefully.
Chrissy? Are you choking? I can help, okay? Stand up. Try and get a breath. Try and get a breath. Let's sit you down. Here.
A person without any air exchange requires your help to survive. If you suspect someone is choking, ask, "Are you choking?" If the person nods yes or is unable to speak, cough, or cry, act quickly. Stand behind the person. Kneel behind someone who is sitting. Reach around and locate the person's navel with your finger. Make a fist with your other hand and place the thumb side against the abdomen just above your finger and below the ribs. Grasp your fist with the other hand. Give a quick inward and upward thrust. Each thrust needs to be given with the intent of expelling the object. Repeat thrusts until the person can breathe normally. If the person becomes unresponsive, carefully lower her to the ground. If not already done, activate the emergency response protocol for the setting. Begin CPR starting with compressions. Look in the mouth for an object after each set of 30 compressions and before giving rescue breaths. Remove any object if seen. Continue care until the person starts to move or another BLS provider takes over. When someone is clearly pregnant or obese, use chest thrusts instead of abdominal thrusts. Position yourself directly behind the person. Reach under the armpits and place the thumb side of your fist on the center of the chest. Grasp your fist with your other hand and thrust straight backward. Try not to put pressure on the ribs. If you are choking, such as falling onto the back of a chair. If one is not available, attempt abdominal thrusts on yourself. Young children are particularly at risk for choking because of the small size of their air passages, inexperience with chewing, and a natural tendency to put objects in their mouths. For a choking child, the approach is nearly the same for adults. It might be easier to kneel behind a choking child to deliver thrusts. Use less force on your thrusts. Because infants do not speak, it may be more difficult to recognize choking. A sudden onset differentiates it from other breathing emergencies. Signs include weak, ineffective coughs and the lack of sound even when an infant is clearly attempting to breathe. If you suspect an infant is choking, act quickly. Lay the infant face down over your forearm with legs straddled and with the head lower than the chest. Support the head by holding the jaw. Using the heel of your other hand, give 5 back blows between the shoulder blades. Next, sandwich the infant between your forearms and turn her onto her back with legs and arms straddling your other arm. Place 2 fingers on the breastbone just below the nipple line and give 5 chest thrusts. Repeat back blows and chest thrusts until the infant can breathe normally. If the infant becomes unresponsive, gently place her onto a firm surface. If not already done, have someone activate your emergency response protocol and begin CPR. Look in the mouth for an object after each set of compressions and prior to giving rescue breaths. Remove any object if seen. Abdominal and chest thrusts can cause internal injury. Anyone who has had these maneuvers used on them should be evaluated further to ensure there are no injuries.
All right, so that concludes our topics, okay, in the basic life support, okay, and I guess the video said it all, okay, for the principles and how to manage the patient in choking or under foreign body airway obstruction. I just like to emphasize that if the patient becomes unconscious, even if the patient has a pulse and breathing, okay, you need to perform the CPR, okay, all right, if the patient, okay, was choked. Okay, all right, that's a different thing. Okay, when we are dealing with the case wherein or in which the patient, okay, initially, okay, has no breathing, has no pulse. Okay, again, okay, if the patient from FBOW or from choking suddenly becomes unconscious, okay, even if there is a pulse and there is a breathing, okay, you need to do the CPR. All right. Okay, so I have a question. Okay, how would you stop, okay, or what is your consideration, okay, for you to stop your CPR or for your basic life support? Okay, you can turn your camera on. Yeah, thank you so much, Mabel. Yeah, okay, turn your camera on. Okay, please turn your camera on because we already finished the basic life support. All right, so there are responses. Okay, when are you going to stop your BLS or CPR? Okay, if okay airway, okay, according to Minera, okay, if the help has arrived, okay, Marie, Arianet, okay, when patient is responsive, already responsive from Marife, okay, if circulation is okay, okay, from Marif, from Minera, patient's response, OPO, ROSC, return of spontaneous circulation, Clarice, yes, too exhausted, if you're too exhausted, yes, okay, Regina. If there is sign of life with pulse and with breathing, yes, Mabel, okay, signs of no life. If the provider is exhausted, yes, even if there is no signs of life, but if the patient is exhausted, okay, Jessica, yes, okay, you can stop your compression or you can stop your BLS. Rescuer is exhausted, yes. ASJ, RAC, RB, too exhausted. Charmaine, responsive to exhausted. Jamela, okay. Stable breathing, okay. Lily, okay. Patient revives, okay. Yes, okay. Minera, okay. Yes, okay. All right, so those are correct, okay. You might want to consider these mnemonics, okay, the STPOS mnemonics, okay, sin has become dangerous to patient to continue CPR, yes, HJ, yes, okay, that's good, that's very good, right? So I have a mnemonic, okay, for you to easily remember, okay, when to stop, okay, your basic life support, okay, and this is STOPS or stops, Okay, the first S is if there is a spontaneous circulation, that is the ROSC. Okay, right. The T is if the trained personnel arrive. Okay, a trained personnel arrive. Okay, it means that a more advanced provider, okay, has arrived. Okay, the O is the stands for a operator. Okay, and you are the operator as provider. Okay, if you are exhausted. Okay, right. The P, okay, stands for physician or protocol. Okay, for example, the physician declared the patient is dead or cannot able, okay, to be revived. Okay, or if the protocol of your hospital, okay, says, okay, that after 30 minutes, okay, we need to stop the resuscitation, okay, with or without the return of spontaneous circulation. Okay, and the last S is if the scene, okay, becomes unsafe or dangerous to continue CPR according to ACE. All right, okay, so again, OPS, okay, stops. S stands for spontaneous return of circulation. Okay, T, trained person has arrived. Okay, O, operator is exhausted. P, physician / protocol consideration, and another S, the last S is if the scene becomes unsafe, okay, or dangerous. Okay, all right. So do you have some clarifications or questions? Okay, can I see you? Can I see your faces one more time before we end the basic life support? Thank you so much, Julius. Okay, yeah. Jamela, Denise, Mary, Arinette, Ruella, Evelyn, Hazel, Regina, Mabel, Ella, Clarice, Sel, Jessica, Oppo. Okay, you have a good name, Oppo. Okay, Catherine, K. Charmaine. Okay, all right. Okay, Mike, yes. Okay, Ella. Okay, all right. Okay, do you have, yes, HJ. Okay, do you have any question? Oppo, what's your name? You're like an Android, Oppo A92. You're muted. Rough. Okay, yes, it's rough. All right. Okay. Any question before we before, okay, you accomplish your process? Okay. Do we have a group here? I mean, a group where you have the same facility or hospitals? None? So you do not know each other? Yes, according to Mabel. Or with your group, Havil, Polymedic. Okay, who are from Havil, Polymedic? Havila Polymedic. Okay, who are from Havila Polymedic with Mabel? Who are those pips? Charmaine? Charmaine, yeah. Janice.
Yes,
Where
sir.
is it? Ah, yeah. Where is it located? Southern Leyte region.
Southern.
Okay, Southern Leyte. Okay, right. Group hemodialysis. Two from who are with Sharina. Janice.
Yeah.
Ralph. Dialysis pips. Okay, else. We're 5 participants. Yeah, Mabel. Yeah. Okay. Sharina, Dr. Nilo Roa Memorial Hospital. Jessica, Josefina Minera from RD Health Serve. Mike, who's with Mike from RD. Beverly, Bianca, Bella, Andrew, with Sharina from Dr. Nilo Roa Memorial Hospital. Okay. Been in Naga. I've been in Naga. Uh, I think 8 years ago. Okay. Yeah, we've conducted a lot of groups. Okay. For the BLS and ACLS. Okay. Me from Vera Catanduanes, Kambal. Okay. So Kambal is from Vera Catanduanes. Yes. Okay. I've already been to Catanduanes as well. Okay, for BLS and ACLS also. All right. Okay. If you do not have any question, okay, I will give the floor to WePump admin, okay, for your post test, and we will see each other again at 12:30. Okay. I think it will be enough for your post test and for your lunch break. Yeah. Because yeah, Maria Lily from RHU 2 back birthing facility. On duty, some may not be able to take the test. Oh, yeah. Well, you can you can you can submit or you can accomplish the test whenever you want until tomorrow. Okay, I guess. Okay, right. Let's ask the WePump admin. Right, I think. Okay, there's a consultation for those who are in duty. You can accomplish it until tomorrow. All right. Okay. All right. So WePump admin, are you there? WePump.
Yes po.
WePump. Just brushing. Yes. Okay. So much. Yeah. Okay, you're welcome. Okay. So I will give the floor to you, WePump admin, okay, for the facilitation of the process. Okay. And again, okay, will be received at 12:30 later. Right. Okay. Have a happy lunch break. Okay, to you guys. I hope to see you all again. Okay, this afternoon. Okay, good afternoon there. Okay, morning, evening here. All right. So thank you so much. Okay. All right. See you after more than an hour. Bye bye.
Thank you, sir.
Thank you.
Nasend ko na po yung link po ng exam po. Pwede nyo pong i-copy link po. Then, pwede po later na lang po kayo mag-take po. Until 7 p.m. po, pwede po mag-submit po.
Okay. Okay. Can you open your cam first? Yes, this will be the first time. Okay, I will ask to open your cam. Okay, and the next would be on the last part of our discussion. Thank you so much. Yeah, Catherine, are you in Japan? Ace J, what's your drama? Are you in Middle East? Hi, baby. Okay, baby Ella. Hi. Okay, guys, you can talk to me. Okay, every time we have a chat like this. Okay, is it or does the rainy season or is it rainy season in the Philippines? Yes. All right, maybe the others are. Yes, Rob, are you saying something? Okay. Okay, let me know if my audio is clear. Am I clear? Yes, yes, okay. Thank you, Angel. Okay, Mabel, thank you. Okay. Um, as I mentioned earlier, we are going to discuss the ECG first, okay, before the other principles in ACLS. Okay, I know, okay, this would be very boring, okay, but I'll try to focus because this is the hardest part of the ACLS. Okay, the analysis and the interpretation of the ECG. Okay. Let me first introduce what the ACLS is. Okay, so advanced cardiac life support is also an emergency cardiovascular care program. Okay, where we have or discussing the principles of the causes, okay, of the cardiac arrest, okay, and the different therapies, okay, such as the pharmacological therapies, electrical therapies, and the mechanical therapies, right? If in basic life support, we are dealing with the cardiac arrest and respiratory arrest alone, okay, in ACLS, okay, aside from the respiratory arrest and cardiac arrest, okay, we need to prevent and monitor the occurrence, okay, of the cardiac arrest. Okay, we have to deal with the dyspneias. That is the reason why we have to discuss the ECG. Okay, we also have the principle of acute coronary syndrome. We also have the principle of stroke. Right? Okay, it means that we are more advanced. No? Okay, in ACLS, okay, compared to basic life support. Okay, all right. There are EMS with basic management, okay, and there are EMS that are doing the advanced management, okay, in the response. Okay, if you are familiar, okay, with an ambulance with an ALS or advanced life support, okay, in their equipment and materials, okay, the staff or the personnel, okay, in that ambulance or in that company, okay, are also advanced. Okay, all right. In other countries, especially in Western countries, okay, they have paramedics. Okay, so the paramedics are like they are like doctors. Okay, they can administer a few medications. Okay, they can do different management. Okay, but is limited only in the ambulance. Okay, they cannot do such things, or they cannot do what the doctors are doing in the hospitals. Okay, there is a course actually, okay, for the paramedics. Okay, in the Philippines, we only have the EMTB or emergency medical technicians basic. Okay, so these EMTs are equipped with the knowledge and skills of providing the basics in emergency cardiovascular care. Okay, so those are the basic life support, okay, basic and advanced first aid in emergency medical responders. All right. Okay, but of course, in the hospital, okay, nurses and doctors are far more equipped. okay, regarding the skills and the the knowledge. Okay, of course, okay, we took nursing for 4 years, and the doctors even more years. Okay, while the EMTB, okay, only consume 2 to 3 months, 4 months, I guess. Okay, but the paramedics, okay, have to do it for 2 years. Okay. All right, cardiac life support, okay, of the American Heart Association and American Safety and Health Institute has 6 topics. Okay, the first topic is the um, ABCDs of emergency cardiovascular care, where in which, okay, there is a discussion of the assessment and an introduction of each topic. Okay, but I'm going to discuss the content of the chapter 1, ABCDs of emergency cardiovascular care, okay, in all of the topics. Okay, it means that I will be incorporating the content of the chapter 1, okay, to each topic. Okay, the chapter 2 is the airway management, basic and advanced, okay, but we will be discussing that tomorrow, okay, not today. Okay, the chapter 3 is the dysrhythmia recognition, okay, and that is the ECG that we are going to talk about this afternoon. Okay, the chapter 4 is the electrical therapy, okay, that is the management of dysrhythmia and cardiac arrest, okay, through the use of manual defibrillator machine. Okay, and pharmacological therapy. Okay, it is they are, okay, with the same, or they are in the same chapter. Okay, the chapter 5 is the acute coronary syndrome, okay, which is simply the myocardial infarction. Well, that's not simple, but what I'm trying to say is, when we are talking about acute coronary syndrome, okay, it means it is an MI, right? The proper term for the MI, or myocardial infarction, is acute coronary syndrome. Okay, and then the last topic, okay, is the stroke. Okay, all right. So going back, okay, to the basic, okay, the cause of cardiac arrest in basic life support, okay, that we are dealing with, okay, is primarily the ventricular fibrillation. Okay, all right, but in basic life support, okay, we do not analyze dysrhythmia. Okay, we have to use the AED in order for us to recognize that there is a dysrhythmia. Okay, but in ACLS, okay, we need to study, or we need to discuss the different techniques and analysis or method, okay, to analyze, okay, the dysrhythmia. Okay, all right. Now in ACLS, okay, we have 3 major causes of cardiac arrest and compromised cardiovascular issues. Okay, these are the dysrhythmias, the acute coronary syndrome, and the stroke. Okay, so these are the 3, okay, most common. Okay, we have to treat, okay, these causes, okay, but first we have to recognize it. Okay, the most important thing is we have to recognize it in order for us to prevent, okay, the cardiac arrest from happening. Okay, so the acute coronary syndrome can easily be recognized through the signs and symptoms, and as well as the ECG analysis, the 12-lead ECG, while the stroke, okay, can be recognized by means of the manifestation. Okay, all right. So we will be discussing the 2 tomorrow. Okay, tomorrow morning. All right, and lastly, yeah, we have the dysrhythmia. Okay, that's what we will talk about today. All right. Okay, so I need your cooperation regarding. Yes, Debbie. Okay. All right. I need your cooperation, because I know, okay, the time, okay, these hours, or the afternoon is really a boring hour, okay, of the day, okay, and you just got your lunch, okay, so it's very tiring, okay? Because you might, I mean, it's siesta time, okay? All right, but I'm stealing your time, okay, to have a siesta, okay, or to have your nap, okay? So bear with me, all right? Okay, and of course, okay, bear with my voice because I actually do not know how to amplify my voice. Okay, this is what I got. Okay, okay. If you have any questions regarding the topic, okay, please let me know. Okay, if there are concerns, okay, please aware me. Okay, all right. I can easily be interrupted. Okay, all right. With of course, okay, your questions. Okay, all right. So now I'm going to share my presentation. Yeah. Okay. So do we have newcomers here? We are, wait, 39. Okay. Earlier in our basic life support, we were just like 33. Okay. Right. So for those newcomers, okay, yes, my name is Rowell Kolala. Okay, and I'm also a nurse. Um, and this is my presentation, okay, for the ECG discussion. This is not similar to the chapter 3, okay, of the ACLS, because I needed to modify this in order for the participants to understand easily. Okay, so I had two references here. Yeah, three rather. Okay, the first reference uh, I want to share with you, okay, is the book of Dr. Goldberg, the clinical ECG. What's the title? It's clinical interpretation of EKG, okay, by Dr. Goldberg. If ever you can able to get one, okay, that is a very good book. And another book is from Dr. Dale Dobbin, the basic ECG interpretation. Okay, so those are for beginners. Well, the basic ECG interpretation by Dr. Dale Dobbin is much easier to understand. Okay, that is for beginners, while the book of Dr. Goldberg, okay, is quite advanced one, but you might want to read the book of Dr. Dale Dobbin before you read, okay, the book of Dr. Goldberg. Okay. All right. Okay. All right. So this course is designed. Okay. Well, I just do this course myself. Okay, this course is designed to emphasize the technique and methods, okay, of reading electrocardiography using focus of origin determination and simple electrophysiology of electrical activity of the heart. Okay, so we are going to focus, okay, on the techniques. Okay, I'm not going to tell you to memorize, okay, the pictures of the different examples of the dysrhythmia, but rather, okay, I will ask you to understand it by heart. Okay, the different techniques, okay, that I made, okay, for you to easily remember, okay, the techniques. Okay, so I always believe that pathophysiology is one of the most important thing in medical field. Okay, you must know the pathophysiology in order for you to know the signs and symptoms you can able to review the basic electrophysiology of the heart, of course, okay, that is our foundation. Learn the normal and abnormal values of the ECG lead waveforms, okay, we'll be presenting to you the characteristics of the waveforms, okay, in which you can able to know the comparison, okay, to normal and abnormal. enumerated the steps in ECG interpretation. Okay, the steps in ECG interpretation is actually the foundation, okay, of the ECG discussion. Okay, you need to assess each waveform in order for you to come up, okay, with an analysis, right? And the last one, okay, is to you the answers. Okay, but yes, I can promise you, okay, 70%, 60-70% of you guys would be able to recognize and analyze it. Okay, I can promise that, but only 60-70%. I know that the remaining 30%. Okay, okay. So let me first differentiate, okay, the 12-lead ECG, okay, from the lead to rhythm strip. Okay, this is an example of a 12-lead ECG strips. Okay, it is called standard 12-lead ECG. Okay, literally it has 12 leads: the lead 1, lead 2, lead 3, AVR, AVL, AVF, and V1 to V6. Okay, so total of 12. Okay, but we have we also have 15 lead ECG and 18 lead ECG, right? Okay, but this is very basic, right? But we're not going to talk about a 12 lead ECG because, man, it's quite difficult, okay, without knowing the basics of a single rhythm strip. Okay, so this is lead 2. Lead 2 is our standard lead for the this is standard, the lead 2 is this standard lead for the analysis. Okay, and this is also the lead that we observe, okay, through the cardiac monitor and the monitor of the defibrillator machine. All right. Okay, so we are going to focus on the lead 2 only, not the 12 lead ECG. Okay. All right. So another example of 12 lead ECG. Okay. All right. So if I'm going to ask you, how would you react if someone tell you to read, okay, a 12 the ECG? It's very hard. I can tell you that. Okay, it's very hard. Okay, but of course, okay, tomorrow, okay, you can able to know how to analyze the ECG, 12 lead ECG, and what are the considerations. Okay, now let's discuss the electrophysiology of the heart. Okay, of course, we have to start with the basic foundation, okay, or the functional unit of the heart. Okay, all right. All organs of the body have this, what we call the functional unit of the heart. Okay, the functional unit of the organ is what makes an organ an organ. It's what makes the organ an organ. Okay, without a functional unit, there is no organ. There's no tissues. There's no muscles. Okay, there is no organ. Okay, so the heart has the heart is very special because it has two functional units. Okay, the first one is the myocardial cells, or also known as the myocytes, and the second one is the pacemaker cells. Okay, the myocardial cells, or also known as myocytes, are the working or the mechanical cells. These are the physical cells that we can see. Okay, if you open your chest, okay, and if you observe the heart, okay, the myocardial cells, it what makes the organ a hollow thing, okay, that we can see. All right, okay, it can contract, okay, and relax, okay, in order for the blood to be pumped into the circulation. Okay, for example, okay, the myocardial cells of the atria, okay, when contract, it can squeeze the blood, okay, down to the ventricle, and when the ventricles contract, okay, it will push the blood into the circulation. Okay, all right. Now, the pacemaker cells are the specialized cells of the electrical conduction system. Okay, it means, okay, that or being special, okay, as a cell, okay, means that it carries all the burdens, no? Okay, to perform, okay, the normal process of the heart. Okay, all right. I've mentioned a while back that the heart needs to contract and relax in order for the blood to uh, to be distributed in all parts of the body. Okay, but before the contraction, or I mean, before it happens, the cells need to be stimulated. All right, and the stimulation, okay, needs an electrical impulse. Okay, the electrical impulse is originated, okay, into the pacemaker cells. Okay, all right. The pacemaker cells are responsible for the spontaneous generation and conduction of electrical impulses. Okay, all right. So we are going to talk about that later on. Okay, how the heart, okay, functions. Okay, okay. Now, these pacemaker cells are under the electrical conduction system. Okay, I know you're familiar with the electrical conduction system of the heart. Okay, the electrical conduction system, okay, is a system or network of pacemaker cells and conducting pathways. Okay, especially, okay, for the delivery of the electrical impulse to all parts of the heart. Okay, again, without the electrical impulse, there will be no stimulation and there will be no contraction. Okay, now let's talk about, okay, the first component, okay, of the electrical conduction system, okay, which is also a pacemaker, okay, that is situated at the right upper part of the right atrium, okay, and that is called the sinus node. All right. Okay, the SA node is considered to be the natural pacemaker of the heart. Okay, and if we're talking about natural pacemaker, okay, all of the electrical impulses must be coming from the SA node. Okay, if not, okay, if the electrical impulse is originated from other pacemakers, then that can be considered as dysrhythmia, or that can be considered as the start of the dysrhythmia, right? Okay, the pacemaker, okay, or the SA node, okay, has or can generate an impulse or impulses about 60 to 100 times, or 60 to 100 impulses per minute. Okay, all right, and that is called inherent rate. Okay, right, inherent rate is the ability or the rate. Okay, I'm going to rephrase it. Okay, the inherent rate is the range of the electrical impulses that a pacemaker can generate. Okay, so the SA node can generate 60 to 100 impulses per minute. Okay, that gives us a normal heartbeat, okay, of 60 to 100, okay, for a normal person. All right. Okay, another pacemaker, okay, that can be found in between the atria and ventricles is the AV node. Okay, the atrioventricular node. Okay, that is why it is called atrioventricular node, because it is in between the atria and the ventricles. Right. Okay, so the SA node inherent rates is 40 to 60. It's lower than the inherent rate of SA node. Okay, right. Of course, there is a purpose, okay, why the inherent rate of the AV node is lower, okay, than the inherent rate of the SA node. Okay, all right. Another pacemaker, okay, that we have, okay, is called his Purkinje system. Okay, unlike the SA node and the AV node, in which we can locate, okay, specifically I mean, we can exactly locate, okay, their location. Okay, the his Purkinje system has no specific cell. Okay, all of the cells in the ventricles can able to generate an impulse. Okay, but of course, okay, there must be one impulse. Okay, there must only be one impulse, okay, to as the origin, okay, of electrical impulse. All right. Okay, now is anyone here or has anyone here would like to tell me why we have different inherent rates, okay, for each pacemaker cells? What is the reason, okay, why these pacemaker cells, okay, have different inherent rates? Okay, do you have any idea? Why do these pacemaker cells need to have different inherent rates? If the normal for the body is 60 to 100, of course, okay, if you have 40 beats per minute, okay, it or it may be it your cardiovascular system will get compromised. Okay, all right. So the normal for the body is 60 to 100. So why do these pacemaker cells need to have different inherent rates? Anyone? I appreciate my audience. Okay, the couple, Doctoleros, yeah. Okay, different excitability. Yeah, close to that. Okay, yeah, Angel, you can elaborate it. Okay, what do you mean by different excitability? Yes, they do have different excitability. Okay, the SA node can generate 60 to 100. The AV node can generate 40 to 60, and the Hespercuity can generate 20 to 40. But what is the reason why? Okay, why is it very important? And why? Anyone? Okay. All right. The differences in inherent rates of these pacemakers are very essential, okay, for the um, for the focus, okay, of the origin of impulse. Okay, we need, or the heart, okay, needs only one impulse, okay, to perform or to be stimulated, okay, to perform its function. Okay, right. If the impulse is generated from the SA node, then all impulses must be coming from the SA node. Okay, right. Even if we have 3 pacemakers, okay, because this is what this is something to do with the prevention, okay, of the irregularities. Okay, so imagine, okay, if all of the cells, or if all of the pacemaker cells can generate impulses, okay, the timing, okay, of the stimulation and contraction, okay, will be irregular. Okay, and the function of the heart, okay, will be compromised. Okay, and as we all know, okay, if the function of the heart, okay, gets compromised, okay, the whole body will be compromised. Okay, because we are talking about circulation. Okay, right, so this is how it functions. Okay, if the SA node is the origin of impulse, okay, then all of the impulses will come from the SA node. If the origin of impulse is the AV node, okay, then all of the impulses will be coming from the AV node. All right. Okay, so there must be only one pacemaker cells, okay, or there must be only one pacemaker cell that is active. Okay, so as long as the SA node is still active, the AV node will remain inactive or dormant, okay, and as well as the Hespercuity system. Okay, the only chance, okay, that the AV node, okay, can generate an impulse is when the SA node, okay, fails to conduct. Okay, right? So they are under the principle of overdrive suppression. Okay, and that overdrive suppression has something to do with the inherent rates. Okay, right? In another explanation, it's something like this. Okay, the inherent rate of the SA node, okay, that is 60 to 100. Okay, overdrive suppress the inherent rate of the AV node, which is 40 to 60, because 60 to 100 is more powerful, okay, than the 40 to 60. Am I clear? All right. Now, okay, if the SA node, which has an inherent rate of 60 to 100, fails to generate an impulse, okay, the AV node, okay, will not anymore overdrive suppressed, okay, by a higher inherent rate, okay. Therefore, the AV node will become active, okay, and will serve as the focus of origin. And that's the same thing, okay, with the hyperKG to the AV node. Okay, all right. So basically, that is the reason why these pacemaker cells can have different inherent rates. Okay, for the principle, okay, of overdrive suppression. All right. Okay. Again, okay, if these three pacemakers generate an impulse all together or right after the other, there will be irregularities, okay, and the stimulation of the heart. All right. Clear. All right. Okay. Now, okay. Another explanation is regarding, okay, the process of the heart is the consideration of the two activities. Okay, we have two activities of our heart. Okay, the electrical activity and the mechanical activity. Right, the mechanical activity is the contraction and relaxation of the cells. Okay, once the cells of the atria contract, okay, it will squeeze the blood into the ventricle, down to the ventricle, okay, to fill the ventricles with blood. Okay, then once the cells of the ventricles contract, okay, it will pump the blood into the circulation. All right. Okay. Now, but before the contraction and relaxation, okay, the cells must be stimulated. Okay, and the stimulation, okay, must be coming from the the stimulation, okay, should be or the stimulation needs the electrical impulse. Okay, the electrical impulse is or must be coming from the pacemaker cell. Okay, now if the SA node release an impulse, okay, it will stimulate first the cells of the atria. Okay, all right, the counterpart of the stimulation, okay, of the cells is the contraction. Okay, all right, and we will call the stimulation as the depolarization. Clear? Again, the stimulation is synonymous to depolarization. Stimulation is like a layman.
Okay.
Okay, Lenny, are you trying to say something? Okay, all right. Again, the stimulation of the cells is synonymous to depolarization. Okay, and depolarization is the electrical activity of the heart. Okay, all right. I've mentioned a while back that we have two activities of our heart. Okay, the mechanical activity and the electrical activity. Okay, the mechanical activity is the contraction and relaxation, while the electrical activity is the relaxation and the depolarization and repolarization. Okay, before the depolarization repolarization happens, okay, a pacemaker cell needs to generate an impulse. Okay, for example, the SA node, okay, generates an impulse. When the SA node generates an impulse, it will stimulate, okay, the cells of the atria. Okay, so there will be a depolarization. Okay, the counterpart of depolarization is the contraction. So it means that if there is a depolarization, or whenever there is a depolarization, there is a contraction. Okay, so the contraction will not happen if there is no depolarization. Am I clear? All right, and the depolarization and that electrical impulse must be coming from the pacemaker cell. Now, if there is no pacemaker cell that can generate an impulse, there will be no electrical impulse, there will be no depolarization, there will be no contractions. Okay, so therefore there will be no circulation. Clear? All right. Okay, and um, there should only be one pacemaker, okay, that should generate an impulse in order for the heart, okay, to perform its normal function, okay, and specifically that electrical impulse must be coming from the SA node, right? If not in the SA node, then there will be a dysrhythmia. Clear? Right? Okay, so remember that now. The SA node, okay, can generate an impulse of 60 to 100. Okay, the AV node can generate an impulse of 40 to 60. Okay, and the his Purkinje system can generate impulses about 20 to 40. Clear? Right? Okay. Now to further discuss, okay, the activities of our heart, okay, focus on this picture. Okay, the SA node generates an impulse. Okay, it will depolarize the atria. Okay, it will go down to the AV node. Okay, and the AV node will regulate the delivery of impulse into the ventricles. Okay, using or through the bundle of V's and bundle branches. Okay, right, to the Purkinje fibers. Okay, and for the depolarization of the ventricles. Clear? Right? So that's how the normal process, okay, of the electrical activity happens. Okay, now the electrical activity, okay, needs to be recorded, okay, by the ECG machine in order to produce these recording. Okay, this is called cardiac cycles. Okay, all right, this is a cardiac cycle, this is a cardiac cycle, another cardiac cycle, and another cardiac cycle. So we have 4 cardiac cycles in our picture. All right. As you can notice here, okay, the cardiac cycles are the same, okay, or the appearance, okay, are the same, okay, right? It means that we have a normal electrical activity, right? So how do these waveforms develop? Okay, yes, Nori. Okay, Wipom, can you give me an access as your co-host? Thank you. All right. Now let's take a look how the ECG machine records this event, okay, or the electrical activity. Okay. All right. And by the way, okay, the E okay, the ECG machine only records the electrical activity. Okay. All right. Okay. So it means that we need to analyze the dysrhythmia in order for us to know if there is a normal electrical activity. Okay. To assess for the mechanical activity, you just need to check for the pulse. Okay, if there is a pulse, there is a circulation. If there is circulation, there is a contraction and relaxation. Okay, and contraction and relaxation is the mechanical activity of the heart. All right. Okay, now let's go back, okay, to this picture. Okay, once the SA node generates an impulse, it will depolarize the cells of the atria. Okay, the ECG machine, okay, will sense that electrical activity and a waveform will be developed. Okay, this is an upward waveform here, right, which we will call a P wave or a Papa wave, right? Okay, so remember, a waveform is a representation of an electrical activity. If there is no activity, okay, there is no waveform. All right. Okay. The impulse will enter into the AV node. Okay. And since we do not have an electrical activity, okay, we can only observe a straight line. Okay. All right. The AV node will use the bundle of V's and bundle branches to deliver the impulse to the ventricles. Again, we have no electrical activity at this time, okay, so the straight line will just continue, right, until the electrical impulse reach the cells of the ventricles, okay, right? Once there is a ventricular depolarization, waveforms will be developed, okay? These are downward waveform, an upward waveform, and another downward waveform. Again, we will label these as Q wave, R wave, and S wave. Okay. All right. So right out of the P wave, okay, we have the Q wave, R wave, and S wave. All right. Okay. And of course, after depolarization, there should be a repolarization. Okay. The repolarization of the ventricles, okay, is represented, okay, by the T wave. Okay, so these are the standard waveforms of the cardiac cycles. Okay, the P wave, the Q wave, the R wave, the S wave, and the T wave. Right? We cannot be able to see the atrial repolarization because its sensitivity is very weak, to the point that the ECG machine cannot able to sense that electrical activity. Okay, so therefore there is no waveform representation. Okay. Any question? Clarification? Okay, again, okay, the P wave is the atrial depolarization. The QRS waves represent the ventricular depolarization, and the T wave represents the ventricular repolarization. Okay. Any question? Any question? And okay. All right. The straight line shall be called the isoelectric line. Okay. And there is no activity happening when we have, or when you are in the isoelectric line. Okay. All right. Another terminologies that you need to know, okay, is the word deflection, the positive and the negative deflection. Okay. So the waveforms that are upwards, okay, are called positive deflection. Okay, they shall not be called upward waveform. Okay, it shall be called positive deflection. Okay, so the P, the R, and the T waves are positive deflections. Okay, while the negative deflections are the downward, okay, waveforms. Okay, the Q and the S waves are negative, okay, deflection. Okay, those are some of the terminologies in the ECG. All right. Okay, so aside, okay, from these terminologies, you also have intervals and complexes. Okay, intervals. Okay, intervals are the measurement of the activity of the chamber. Okay, for example, okay, the PR interval, okay, is measured from the beginning of the P wave to the beginning of the QRS complex. Okay, so it measures the depolarization, repolarization of the atria. Okay, the QT interval that can be measured from the beginning of the QRS complex to the end of the T wave measures the or covers, you know, the QRS and the T, okay, in which they are representing the ventricular activities. Okay, so the QT interval, okay, can measure the activities of the ventricles. All right. Okay, the complex, okay, is a composition of two or more waveforms. Okay, representing an activity. Okay, since the Q, the R, and the S waves represent the ventricular depolarization, okay, it shall be called QRS complex. All right. Am I clear? Well, I'm just referring to how Annabelle and I suppose her husband is reacting. Okay, because you guys are the only one who has an open camera. Okay, all right. Is that clear? Yeah. Okay. All right. Okay. Now, let's talk about the normal and abnormal values of the waveforms and complexes. Okay. All right. Each waveform has, or each part, okay, of the cardiac cycle, okay, has definition, description, and characteristics. Okay, the definition is the a reference, okay, for the normal value. Okay, all right, or the normal deflection. Okay, the description, okay, is the appearance or the overall appearance, okay, of the waveform, okay, whether it is positive, okay, or it is negative, or it is absent. Okay, all right, and the characteristics dictate um, the technical measurement, okay, of the waveform. Okay, I mean, for example, the height, okay, and the width, okay, of the waveform. Okay, for example, okay, in P wave, okay, the definition of the P wave is the first positive deflection, okay, of the cardiac cycle. Okay, so the first positive deflection, okay, if we are talking about the first positive deflection, you must start, okay, labeling the parts of the cardiac cycle with the P wave. Okay, there shall be no other waves that must be situated at first. Okay, it must only be the P wave. All right. Okay. All right. So the first positive deflection of the cardiac cycle. Okay. The description of the P wave, okay, can be positive, can be negative, or absent. Okay. Again, when we're talking about positive, it means that is upward. Okay. If negative, that is downward. Okay. And if it's absent, then it cannot be observed. Okay, flat. No. Okay, we can only observe an isoelectric line. All right. Okay, so but if I'm going to ask you the normal deflection of the P wave, what would it be? Positive. Yes. Okay. Yes. Okay, thank you so much. Okay, Mr., can you give me your name? Is I just know Annabelle.
Janito Doctolero, sir.
I'm sorry, sir.
Janito Doctolero.
Janito.
Yeah.
Janito.
Yeah. Okay.
All right. Thank you so much, Janito.
Okay.
Okay. All right. So Janito answered positive because we have to always refer to definition, okay, for the normal deflection. Since in P wave, the definition is the first positive deflection, then the normal deflection would be positive. Okay, so it means that negative deflection, okay, is abnormal. The absent P wave is also normal. All right. Now, okay, the characteristics of the P wave, okay, again, it means height and the height and the width. Okay, the height of the P wave must be 0.5 to 2.5 millimeters. Okay, while the width must be 0.10 seconds or 0.10 second. Okay, no S. Okay, 0.10 second or less. Okay, so how can we know these measurements? Okay, of course we need to refer to the ECG paper. Okay, so the ECG paper is like this. Okay, well, not totally like this, okay, but okay, if you have an ECG paper with you, okay, it is composed of small squares and big squares. Okay, so the small squares that I'm talking about is this one, okay, and the big square is this one, okay, in which there are 5 small squares vertically and 5 small squares horizontally. All right. So we have 2 axes here, okay, the vertical and the horizontal. All right, now let's extract a small square. Okay, let's get here. One small square vertically has a measurement of 1 millimeter. Okay, all right, 1 millimeter, and one big square, okay, 5 small squares vertically, it has 5 millimeters measurement. Okay, because 1 times 5 is 5. Yeah, you can, Janito, Annabelle, you can mute your audio.
So
Annabelle.
0.04 times 5 squares, so that is 0.2. Okay.
Yes, Annabelle, can you mute your audio? Yeah, thank you so much. Okay, all right. Again, okay, we have 1 millimeter, okay, for one small square and 5 millimeters in one big square. Okay, all right. Horizontal, in horizontal measurement, okay, we have 0.04 second. Okay, yeah, the unit of measurement, okay, for this is second. Okay, because horizontal axis, okay, we can assess for the time, okay, of the activity or the electrical activity. Okay, so one small square is 0.04. Okay, and in one big square, since we have 5 small squares, okay, we have 0.20 second. Okay, 0.04 times 5 is 0.20. The 0.04 plus 0.04 is 0.08 plus 0.04 is 0.12 plus 0.04 is 0.16 plus 0.04 is 0.20. All right, okay, so that's how we get the 0.20 second. Right, now the normal value, okay, of the height, okay, of the P wave is 0.5 to 2.5 millimeters. Okay, so can you tell me how many small squares do we have vertically? If our P wave is 2.5 millimeters, how many small squares do you have? Anyone? Anyone? Yeah, it's 2.5. Okay, yes, Ace, half, no, Janice, yes, 2.5. Okay, because 2.5 is 2.5. Okay, I mean 1 millimeter is one small square. Okay, so we're talking about 2.5 because so that is 2.5. Okay, or 2.5. Okay, so that's the answer came from Janice and Jazreel. Okay, 2.5. Yes. Okay, what about the width? Okay, if we're talking about the width that is 0.10 second or less, okay, let's say we have specifically 0.10 second width of the P wave. How many small squares do we have horizontally? Horizontally. How many small squares? 2.5. Okay, according to Ace, yes. Okay, because 0.04 plus 0.04 is 0.08. Okay, if we add another small square horizontally, that would become 0.12. We only need 0.10. Okay, so you need to divide one small square. Okay, the last small square, so it would make 2.5. Okay, all right, so you always convert from the technical measurement to the small squares. Okay, because there is no measurement in the ECG paper. Okay, you need to do it yourself. All right, okay. All right, so let's go back to the P wave. The P wave is usually followed by QRS complex. Okay, again, the P wave is the representation of the atrial depolarization. We all know that after the P waves, after the atrial depolarization, okay, the ventricular depolarization is next. Okay, so you have to always observe the QRS complex or the presence of the QRS complex every after the P wave. Okay, all right. Okay, let's have an example of the P waves. All right. Okay, this is a cardiac cycle. Okay, and if you compare this portion, okay, to the other portions, okay, they are the same, right? Okay, all right, so that's how it is. Okay, all right, so this is your P wave, okay, and this is your QRS complex, okay, while this is your T wave. All right, okay, now if I'm going to ask you what would be the deflection of the P waves in the letter A example. Okay, what would it be? Is it positive, negative, or absent? Okay, yes, positive according to RD. Okay, positive. Okay, all right. Then you need to compare, okay, the first P wave to the other P waves. Okay, all right. Are they identical or different? Because the normal is identical. Okay, it must be identical. Yes, according to Julius, it is identical. Okay, all right. If there is even one P wave that is not the same with the other, okay, then the whole picture or the whole lead, okay, has a different description. Okay, we only have 3 descriptions here provided. Okay, the positive, the negative, and the and absent. Okay, right, but this is not the final descriptions. Okay, you need to know, okay, if the P waves are identical or different. Okay, all right. So in letter A example, okay, since the P wave are identical, okay, the description would be positive and identical. Okay, positive deflections and identical P wave. Okay, clear? Okay, so this is the normal. Okay, once there is a P wave that is not similar to the other P wave, then we have an abnormal description. Okay, clear? Okay. What about in letter B example? Can you tell me the description of the P wave? Can you tell me the description? Is it positive identical, negative identical, or different P waves, or absent P waves? Negative, but it's incomplete. Okay, negative is incomplete. You need to know if the P waves are identical or unidentical. Yes. Okay, Rulin, okay, says negative identical. Okay, yes, Janice identical. Okay, then we have a description, okay, of negative identical P waves. Okay, so this is our cardiac cycle. Okay, this is our P wave. Okay, this is our QRS complex. Okay, and this is your T wave. Okay, and this portion, okay, is similar to the other cardiac cycles. Okay. Okay, what about in letter C? Okay, how would you describe the P wave? No discernible P wave, yes. Okay, and it's absent. Okay, from Julius and Janice. Okay, so the P waves are absent. Okay, of course. Okay, if we have an absent P wave, then we have an abnormal variation. Okay. Okay. All right. Moving on to the next example. Okay, this is your cardiac cycle. All right. Okay, how would you describe the P wave? In letter E example. No, I'm talking about description. Okay, we are just in the description topic. Okay, because wide is a characteristic. So how would you give me the description of the P wave? Description. Is it positive identical, negative identical, absent, or different P waves? Positive identical, okay, from Janice. Okay, Julius, yes. Okay, all right, because this is your P wave, okay, that is positive, okay, and very similar to the succeeding P waves. Okay, all right. What about the letter F example? How would you give me the description? Positive identical, okay, from Julius. Okay, positive identical. Okay, yes. Okay, so this is your first P wave and the other P wave that is very similar to the first. Okay, now we are talking about the description. Okay, now let's talk about the characteristics. Again, characteristics is something to do with the width, okay, and the height. Okay, can you give me the characteristic of the P wave here? Okay, what's the height and what is the width? Of course, you need to count the small squares vertically and horizontally. You just approximate. Okay, if you are having a hard time looking at the small squares, okay, you can approximate the numbers of small squares. Okay, again, okay, for the characteristics, you need to know the height and the width. Okay, so for the letter A, okay, how would you measure the characteristics of the P wave? 2.5 millimeters and 0.10 seconds to any half small squares, according to Janice. Yes, very good, perfect. Okay, all right, so it means that the characteristic of our P wave, okay, in letter A example is normal. Okay, all right, I'm not going to ask you the letter B example. Okay, now in letter E example, okay, how and it says in the caption that it's wide. Okay, so how would you give me your measurement? Okay, well, actually, I can zoom this for you. Okay, but yeah, okay, like this. Okay, 'Can you see it clearly when I zoomed it? Okay, it's 4. Yeah, yes. Okay, from Regina, it's yes, actually 3 to 4. Okay, but closer to 4 small squares. Okay, from Regina. Okay, all right, it's 4. So it means that it is wide. Okay, all right, the notching of the P wave happens, okay, when there is a widening. Okay, so always remember that. Okay, if there is a widening of the P wave, or if there is a widening of the wave, okay, the notching, okay, is possible. Okay, all right, what about the letter F, P wave? Okay, how would you give me the characteristics? Five millimeters from Janice. Yes. Okay. Very good. Okay. 5 millimeters. Okay. 1, 2, 3, 4, 5. Yes. Okay. So it's tall. Okay. The P waves here are tall. Okay. 5 millimeters. Okay. Let's get it back. Okay, but no, okay, if you're asked about the description, okay, both are positive and identical. Okay, all right. In letter J example, okay, we cannot compare it, okay, to other cardiac cycles because we only have one cardiac cycle. Okay, but I want you I want to emphasize, okay, the characteristic, okay, I mean how we give, okay, the characteristic of the P waves in letter G and letter E. Okay, can anyone tell me the characteristic of the P wave of letter G example? What's the measurement? It's, yes, okay, 1 millimeter or from 0.5 to 1 millimeter Julius. Yes, okay, all right. So the word flat is not absent. Okay, remember that. Okay, all right, because if we consider the flat as absent, then the girls might get angry with us. Okay, right, girls? Flat means there is still something, okay, that is, yeah, well, actually it's a joke. Okay, all right, what about the letter H example? Okay, how would you measure, okay, the P wave? Remember, flattening is not absence. Okay, there are a lot of no, I should not continue. And letter H example, okay, anyone? Anyone? Oh, yes, no, Julius, yes, but it's closer to 1 millimeter. Okay, yes, 1 to 2, okay, will do. Okay, all right, Julius, yes. Okay, all right, now, it can be small pointed, but it doesn't matter, okay, as long as you measure it, okay, it's normal. Okay, all right, now I'd like you to imagine a lead, a recording, okay, with 4 cardiac cycles. Okay, the P wave, where the P wave of the first cardiac cycle looks like this one, okay, and second P wave looks like this one, the third looks like this one, and the H looks like this one. How would you give me the description of that lead? Again, try to imagine a lead recording, okay, with 4 cardiac cycles, okay, where the P wave of the first cardiac cycle looks like the P wave of letter E example. Okay, the second, the P wave of the second cardiac cycle looks like the F P wave. Okay, and on the third cardiac cycle looks like the P wave of the G example. Okay, and the last P wave looks like the H example. Okay, how would you give me the description of the P waves? We have 4 descriptions, right? Okay, positive identical, negative identical P waves, absent P waves, and different P waves. So choose among the 4 descriptions. Different P waves, exactly. Okay, Janice. Okay, yes. Okay, that's what I would like to see. Okay, different P waves. Okay, now in the letter I example, okay, this is actually a P wave, another P wave, and another P wave. Can you give me the description of the P wave? Yes, Kambal. Okay, this is different. These are different P waves. Now I'm talking about the descriptions. Okay, I'm talking about the description. Okay, how would you give me the description of the P wave? here in letter H example. Letter I, rather. Now, give me the description. Don't jump up with words that you can see, okay, as caption. Okay, Julius, yes, different P waves. All right. Now, if we have a different P waves, okay, basically, okay, it refers to either a solid pattern of the P wave, okay, solid pattern of the P wave, or wavy P waves, okay, all right. If you have a solid pattern of the P wave, okay, where the P waves are consecutively occurring, okay, with different description, okay, or way, yes, this one first, okay. If you encounter a solid appearance of the P waves where the P waves are different, okay, it is more likely to be called as flutter, right? But if the P waves are wavy, okay, so we have a P wave, we have P waves here that are either or a combination of small and flattened P waves, right? Okay, all right. It can be captioned as wavy P waves. Okay, if you encounter a wavy P waves, okay, this can be called fibrillation. Okay, because when we're talking about fibrillation, it's just quivering. Okay, all right. Okay, and the ECG machine can record exactly, okay, what is happening in our heart, right? Okay, but then again, okay, we will go and talk about that later. Okay, any question, okay, regarding the P waves? Any clarification? Okay, we're going to take a break at 2 p.m. Okay, now let's move on to the PR interval. Okay, at the time that the impulse takes place to move through the atria to the AV node. Okay, this is the measurement. Okay, okay, from the beginning of the P wave to the beginning of the QRS complex. Okay, and the normal value, okay, has something to do with its length. Okay, the length from the beginning of the P wave to the beginning of the QRS complex, okay, and that is normally 0.12 to 2.20 seconds. Okay, all right. How many small squares are we talking about? Okay, in 0.12 to 0.20 seconds. Anyone? Again, you have to always convert, okay, from the digits to small squares. Okay, so how many small squares are we talking about here? 0.12 to 0.20 seconds. Anyone? 0.12 is how many small squares? And 0.20 is how many small squares? 3. Okay, yes, Regina, 3. The 0.12 is 3. What about the 0.20 seconds? 3 to 5. Angel, Emil. Okay. Angel, Emil. Okay. All right. 3 to 5 small squares. Okay, exactly. Yeah, so this is normal. Okay, this is a normal value. Okay, now the description of the PR interval, okay, can either be prolonged or normal. Okay, normal is 0.12 to 0.20 second. Okay, while the prolonged is of course more than, okay, 0.20 second. Okay, all right, let's take a look at the examples. Okay, let me first all right, in the letter A example, okay, let me zoom in. Okay, we have okay, 5 small squares, and that is 0.04 second. Okay, all right. Is it normal or abnormal? Is it prolonged or normal? It's normal. Okay, because our normal is 3 to 5 small squares. Yes. Okay. Yes, Kambal. Do you actually have um that name, Kambal? Is it your true name, Kambal, or it's just a nickname? Just a nickname. Okay, all right. Okay, what about the letter Z example? We have 9.5. Okay, 9 to 10 small square. Is it normal or Maria Cinderella Hawson? Okay, yeah, Maria Cinderella Hawson. Sounds like fairy tale. Huh? Maria Cinderella. All right, so letter Z example. Okay, how would you give me the description of the pure interval? Yes, prolonged pure interval, Angel. Okay, yes, okay, we have a prolonged pure interval. All right, now, okay, the short pure interval, okay, that we can observe here at letter B example. Okay, I'm sorry for, yeah. Okay, the short pure interval that we can observe here, a letter B example, okay, in which you can only observe 2 small squares. Okay, can be normal or abnormal. All right, because our normal, okay, or the normal range of the pure interval must be 0.12 to 0.20 second. Okay, and that is 3 to 5 small squares. But in this case, okay, we only have 2 small squares. See, so it can be normal or abnormal. Okay, if we consider another case, okay, the case that I'm talking about is the pre-excitation syndrome. Okay, all right. If you're familiar with the Wolff-Parkinson's-White syndrome, can anyone here familiar with the Wolff-Parkinson's-White syndrome? Wolff-Parkinson's-White syndrome is a pre-excitation syndrome in which the flow of the electrical impulse from the SA node, okay, goes directly to the ventricle, bypassing the AV node and the bundle of His and bundle branches. Okay, all right, due to the extra fiber. Okay, but it's not included in the basic. Okay, what I'm talking about is if you have a small square, I mean, if you have a very short pure interval, okay, and you observe a delta wave, the delta wave is the sudden take off of the QRS complex like these, okay, right, or just like this one, okay, all right, from this your P wave, okay, right, a sudden take off of the QRS complex, okay, you have a pre-excitation syndrome, okay, and that is the only time that we can consider the short pure interval as abnormal, okay, but nevertheless, okay, this is normal. What you can see here is normal. All right, okay, any question regarding the pure interval? Okay. All right, now let's move on to the QRS complex. Okay, again, QRS complex is a composition of 3 waves, the Q, the R, and the S waves, and it represents ventricular depolarization. Okay, the significant measurement for the QRS complex would be its width. Okay, that is measured from the beginning, okay, here to the J point. All right, to the J point. The J point is where the QRS complex returns to isoelectric line. Right? Okay. And it should be less than 0.12 second. Okay, so again, 0.12 second is 3 small squares. So the normal is 2.5 small squares. I mean, less than okay, 3 small squares, okay, but the descriptions, okay, for the QRS measurement width, or the width of the QRS complex, can either be narrow or wide. Okay, narrow is if the QRS complex is less than 0.12 second or 3 small squares, and wide is if it exceeds more than 3 small squares. But okay, in some book or most of the ECG books, okay, the 0.12 second or 3 small squares can be considered as a wide QRS. Okay, all right. So let's take it as the standard. All right. Okay. Now the J point, okay, is the end of the QRS complex. It's where we measure, okay, the point of the end of the QRS complex, not the S wave, right? Because sometimes, okay, the QRS complex has no S wave, all right? Okay, and that is normal. Okay, for example, okay, in the third example, okay, let me zoom it for you. Okay, you only have an R wave actually here. Okay, right, but it can also be considered as QRS complex. All right, okay, because QRS complex, because I mean, the R wave can stand alone to represent the QRS complex, even without the Q wave and even without the S wave. Okay, we can still call this as QRS complex. So if you have this kind of QRS complex, okay, this is the J point. Okay, it doesn't goes from the S wave. Okay, it goes directly from the R wave. Okay, okay, and you will encounter that later on, okay, in our examples. All right, but again, okay, the most important measurement for the QRS complex is its width. Okay, it's either narrow or wide. Okay, so remember that. Okay, now let's discuss each waveform under the QRS complex. Okay, the Q wave. Okay, the Q wave is the definition of the Q wave is the first negative deflection after the P wave. Okay, so if there is a negative deflection or the negative, I mean, downward waveform, okay, after the P wave, okay, that must be labeled as Q wave. All right, okay, okay. Remember that Q wave can be absent normally. Okay, just like what I've shown to you, okay, a while back. Okay, the R wave without Q and an S wave. Okay, it can be normal in other leads or even in lead 2. Okay, and we can consider it as normal. All right, okay, we're not going to talk about Q wave further because it's under the acute coronary syndrome. The presence of very deep Q wave signifies a necrosis, okay, and that is under the acute coronary syndrome. So I'm going to jump to the R wave. Okay, the definition of the R wave is the first positive deflection following the P wave, if there is no Q wave, or following the Q wave, right? Okay, so if there is even a small deflection that is positive after the P wave, it must be labeled as an R wave, okay? In basic ECG interpretation, we're not dealing with the height of the R wave, nor the height of the QRS complex or the S wave, right? Okay, the most significant measurement is the width of the Q wave. All right, but I would like to show to you the differences of the height of the R wave in the chest leads. The chest leads are from V1 to V6, okay? And as you can observe here, okay, there is a very small R wave, okay, in V1, okay? And it progress to V2, okay, right, to V3 and V4, and it recedes actually, okay, to V5 and V6. If you line these chest leads horizontally, this is what you get. Okay, small R wave at V1, it progresses up to the V2, V3, and V4, and it recedes to the V5 and V6. Okay, it is called normal R wave progression. Okay, well, this is not that important in the ECG interpretation or in the treatment recognition, okay, but in 12-lead ECG. So I'm going to hang you, okay, we're not going to discuss this further. Okay, all right, now the S wave is the negative deflection following the R wave. Okay, you cannot label the S wave without the R wave. Okay, and again, S wave can be absent normally. So the bottom line, okay, it all boils down to the R wave. The QRS complex all boils down to the R wave only. Okay, all right, again, okay, if there is only one wave that is present, okay, and the QRS complex, okay, it is normal, okay, and you have to label it as R wave. Still an QRS complex. I mean, it's still a QRS complex. Clear? Question? Okay, now and we're not going to talk about the J point, the S segment, because its importance is under the acute coronary syndrome. Okay, all right, now the last standard wave of the cardiac cycle is the T wave. Okay, that is the last positive deflection. So again, okay, the normal deflection or the normal description of the T wave is positive. However, it can be negative at some cases. Okay, but if it is negative, it is definitely abnormal. Okay, the significant measurement gives okay, the significant measurement for the T wave is height, okay, from the baseline, okay, which is isoelectric line, okay, to the top, okay, of its curvature, okay, which is less than 5 millimeters, okay, and that is 5 small squares. Okay, if it exceeds more than the 5 small squares or 5 millimeters, of course, okay, it signifies a problem. All right. Okay, now let's take a look at the examples of the T wave. Okay, in letter A example, okay, we have how many small squares? Can anyone tell me the measurement, okay, of the height of the T wave? I'm getting sleepy. Can anyone tell me the height of the T wave in letter A example? Anyone? It should be measured from the isoelectric line or baseline here. Come on, guys, you can do it. How many small squares do we have here? 4. Yes, Regina. Okay, we have 4 small squares. Okay, 1, 2, 3, and 4. Okay, so we have a normal height of the P wave. Okay. All right. What about in letter C example? Okay, how would you give me the measurement of the height of the T wave here? Seven, yes, Regina. Okay, yes, no, approximately 7. Okay, A is J, yes, 7 millimeters. All right, now 7 combined. Okay, Maria Cinderella. Yeah, Maria Cinderella. Okay, all right, 7 small squares. Okay, now the peaking of the T wave signifies either a hyperkalemia or an acute ischemia, right? Again, either a hyperkalemia or an acute ischemia. All right, so we might want to know, okay, the cause, okay, through a laboratory test. No? Okay, if the potassium is normal, then it is an acute ischemia. Okay, but if the potassium is high, then this is hyperkalemia. Right. All right. What about the letter D example? Okay, what is the description? Positive or negative? Negative. Okay, Regina. Okay, negative. Yes, RD Charmaine, negative. All right. Okay, negative T wave, okay, signifies ischemia as well. Okay. Okay, ischemia as well. Okay, but not an acute one, right? Okay, there is another wave, okay, that is not included in the standard waveforms of the cardiac cycles, but yeah, okay, it can be seen, okay, in some cases. Okay, it is the U wave. It is small rounded deflection, sometimes seen after the T wave. It is believed, okay, that the presence of the U wave, okay, normally is just the last phase of the ventricular repolarization, but it can be a sign of hypokalemia, okay, if the T wave is flattened. Okay, again, if the T wave is flattened and there is a U wave, this is a sign of hypokalemia. Okay, but if the T wave is normal, then there is a small rounded deflection right after the T wave that is a part of the T wave. Okay, the last phase of the ventricular repolarization. All right. Question? Question? Oh, it's already 2:06. Okay. 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 Now, knowing these normal values, knowing these normal values of the waveforms and complexes, okay, is not enough to analyze or interpret an ECG. Okay, we still need to know, okay, how to obtain, okay, the or how to use the steps, no, okay, in analyzing rhythm strip. Okay, and these are calculating the rate, determining the regularity, identifying the P wave, measuring the pure interval, measuring the Kuros complex, and finally, okay, locating the origin. Okay. In our previous discussions, okay, about the normal and abnormal values, okay, we can able to identify. Okay, we can already able to identify the P waves. Okay, it's something to do with the description. Okay, it's either positive identical, negative identical, absent, or different. Okay, and we already knew, okay, how to measure the pure interval. Okay, if it's normal or prolonged. Okay, and what about the Kuros complex? It's either we still have three problems to discuss this after our 10-minute break, because 1 hour and a half, okay, has just passed easily. All right, I normally discuss the introduction for 30 minutes, but yes, okay, I was enjoying your participation, so it prolongs. All right, okay. Just leave your questions if there uh, uh if there are questions. Okay, just leave it in the chat box. Okay, and we will address it. We will answer it after 10 minutes. My time is 2:08 and we will resume at 2:18. Okay, I will leave the slides with you. I will leave the slide with you. Coffee Shack Shack. Okay, yes, Angel, Coffee Shack Shack. Okay, I need to drink coffee because it's 2:08 in the morning here. Okay, so I'm so sleepy. Okay, right, so see you after 10 minutes. All right, now let's talk about the regularity. How can we determine the regularity? Actually, okay, it is the easiest step, okay, amongst these six steps. Okay, we just need to measure the R to R, okay, intervals, okay, and compare, okay, to all intervals, okay. If the intervals are the same, okay, then we have a regular rhythm, okay. If there is even one or even just one interval, okay, that prolongs or shortens, okay, we can consider is as a irregular, right? Okay, again, okay, our parameter, okay, is the measurement, okay, of each intervals. All right, now let's have an example. Okay, can you tell me if this is regular or irregular? Regular or irregular? Regular from RD. All right, okay, what about the next one? Regular or irregular? Is it regular or irregular? Irregular, okay, from Eugenia. Yes, irregular. Cancer, Dianara, okay. Charmaine, okay, yes. Okay, Catherine, okay. Because we have an obvious lengthening of the first and the second interval, and of course, okay, compared to this interval and this one. All right, what about this one? Okay, do we have an irregular or regular rhythm? Regular, okay, according to RD, okay, according to Roland, okay, yes, regular, okay, Mike, yeah, right.
Regular.
Dinora.
Regular.
Regular, okay, yes, yes. All right, okay, what about this one? Regular or irregular?
Regular.
Yes, irregular. All right.
Regular.
What about this one? Regular or irregular? Regular, RD, yes. Okay, Dr. Lero couple. Okay. Regular, okay, Jezreel, regular, yes, okay. We can actually or easily recognize regularity and irregularity if the cardiac cycles are near, okay, to each other, or let's say the rate, okay, is very high. Okay, all right, now what about this one? Okay, do we have irregular or regular rhythm?
Regular, doc.
Regular. Regular, okay, right? And also from Jezreel, Mike, Diana. Dianara is a term or a name of Indian, right? Dianara. No. Well, where can I get? Where did I get it? Dianara. All right. It's a beautiful name. Anyways, we've already known how them. Okay, now let's move up to the rate calculation. Okay, if you're given a tracing or a lead two like this, how would you calculate the rate? Okay, you just have to in practice, okay, you just need to look at the monitor and you can easily know the rate of the patient. But if you are given, okay, just a lead like this, okay, how would you able to calculate for the rate? Okay, we have different techniques on how to identify or how to calculate the rate, but I will discuss with you the two most common techniques. And the first one is the rule of 300, okay, in which or you just need to memorize this numbers, okay, 300, 150, 175, and 50. Okay, is this sequence. Okay, yeah, to memorize this sequence: 300, 150, 175, 60, and 50. 30 seconds. Okay, done. All right, okay, so to use this sequence, all you need to do is to get a cardiac cycle, okay? Oh, let's say, for example, okay, this is your lead. Okay, get a cardiac cycle with an R wave falling on a bold line, all right? Okay, you have to choose an R wave falling on a bold line. The bold line that I'm talking about is the or are the boundaries of the 5 small squares. Okay, so remember that we have big squares. It's composed of 5 small squares horizontally and 5 small squares vertically. Okay, so you need to get or choose an R wave that is falling on a bold line. Okay, and you substitute the sequence number. Okay, starting with 300 on the next bold line. Okay, so 300 here, substitute to 150 here, 100 here, and so on and so forth, right? Okay, now your calculated rate is where your second R wave or wherever the second R wave falls. Okay, for example, okay, then the second R wave falls on the 60 sequence number, then your calculated rate is 60. Okay, that is very simple. Okay, but if this second R wave falls in between 60 and 75, you just have to approximate. For example, the rate is 60 to 75. Okay, do not get the mean, okay, of 60 and 75. Okay, just say 60 and 60 to 75. All right. Okay, or 75 to 100, or 100 to 150, or 150 to 300. All right. Clear? Okay, so that is the rule of 300 is only for regular rhythm. Okay, it is only applicable for regular rhythm. Now, for irregular rhythm, we need to follow the precise rate calculation. Okay, in precise rate calculation, okay, you have to focus on this because this is very confusing. In precise rate calculation, you have to cut 3-second strip. Okay, in order for you to cut, in order for you to know, okay, how to cut a 3-second strip, you need to, of course, do the mathematics. Okay, for example, okay, in one small square, okay, we have 0.04 second. Okay, in one big square, you have 0.20 second. Okay, so in 1 second, okay, you have 5 big squares because 0.20, okay, plus 0.20, we have 0.40 plus 0.20, we have 0.60 plus 0.20, we have 0.80, and plus 0.20, we have 1. So you have 5 big squares in 1 second. We need 3 seconds for this calculation. So you need to count 15 big squares, and that is equivalent to 3 seconds. Okay, so in this example, okay, you from here, okay, to here, you have 15 big boxes. Okay, it means that you have 3 seconds. So in 3-second strip, you need to count the numbers of cardiac cycles, 1, 2, 3, 4, 5, 6, and multiplied by 20. All right. Okay, so 6 times 20 is 120. Okay, that is our calculated rate. Okay, and is applicable to both regular and irregular, but you have to practice using this for irregular only. Okay, because it will take time. It will take time to use this in regular. Okay, all right. Now, if your rate is very slow, as evidenced by very far interval of cardiac cycles, okay, you need to use the 6-second strip. Okay, of course, in 6-second strip, you have to count 30 big boxes. Okay, and again, same procedure, same steps. You need to count the number of cycles within the 6-second strip and okay for 6-second strip. All right. Okay, let's have an example. Okay, can you all right, can you calculate this for me? I'm waiting in the chat box. This is regular, so you have to use the rule of 300. So can you give me the calculated rate here?
$60.
Recalculate. 50 to 60, according to Regina, yes, okay, it's 50 to 60. Is it 50 to 60? Let us suppose this is your R wave. Okay, so you have to substitute the sequence number starting here. 300, 150, 175, 60, 50. Okay, all right. So the second R will fall exactly on a bold line where the 50 sequence number is substituted. So your rate is 50. Clear? Now it's 50. Okay, again, okay, if this is your chosen R wave that you have to choose because it's near or it's falling on a bold, okay,
150.
yes, you need to substitute the sequence number starting on the next bold line, 300, 115 here, 175, 60, and 50. Okay, so it so happened that the next R wave from the first chosen R wave falls on the 50 sequence number, so your rate is 50. Clear?
Yes.
Okay. Another example. This is regular, so you have to use the rule of 300.
Regular.
Okay. Give me the calculator rate. The substitution of the 300 must be on the next bold line. Okay, yes, Janice, it's to the 300. Okay, because for example, if this is your chosen R wave, it falls on a bold line. Okay, substitute the 300 here and 150 on the next bold line. Okay, but this time your next R wave falls in between the 150 to 300 and 300. So your rate is 150 to 300. Thank you, Janice. All right. Okay. What about this one? This is irregular, so you have to use the precise rate calculation.
300, 150.
No, you have to use the precise rate
100.
regular.
150 to 100. Sa 300, 150, 100 hindi. 150 to 100 to 150.
Guys, you have to use the precise rate calculation because this is irregular. Precise rate calculation, you have to count 15 big boxes to get a 3-second strip, and within that 3-second strip you have to count the cardiac cycles, the number of cardiac cycles, and multiply by 20. It's 60, yes, Dayanara. Okay, this is where your 3 seconds ends. Okay, because from here to here is 15 big boxes, so it means this is 3 seconds. You have to count the cardiac cycles within the 3 seconds or a 3-second strip, okay, and multiply by 20. Okay, so 3 times 20 is 60.
60.
Right? Okay, I hope I am clear. Okay. This is also irregular. Okay, so use the precise rate calculation.
One, two, three, 4, 5, 6, 7, 8. 8, 3, 8. 80. 80.
Yes, yes, 80. Okay. All right. So 80 is this is where we
8
yeah.
times 10.
Yes. Okay. Right. So from here to here, this is your 3-second strip. Okay. We have 4 cycles divided by 20. That is getting us a result of 80. Okay. All right. So that's how we calculate for the rate. Okay. Okay. So we've already discussed the first 5 steps. Okay. Now it's time to know how to identify or locate the origin. Okay, now the importance of the origin is we can easily name the dysrhythmia if we know the origin of impulse. Okay, for example, okay, for example, we have a sinus rhythm, or we have an atrial flutter, or we have a junctional tachycardia or a ventricular tachycardia. Okay, so these types of dysrhythmias have 2 names. The first name is related to the origin, actually. Okay, all right, so that is the importance of knowing the origin. Okay, you can able to get the first name of your dysrhythmia, right? Okay, but of course, okay, you need to know, okay, the different origins. Okay, so we've already talked about the different origins. Okay, we have the SA node, we have the AV node, we have the His-Purkinje system, and of course we have the atrial pacemakers. Okay, so aside from these 3 pacemakers, specifically under the electrical conduction system, okay, we also have atrial pacemakers. Excuse me. The atrial pacemakers are the cells of the atria. Okay, actually all cells in our heart are capable of releasing or generating electrical impulse. Okay, but of course, okay, since we are dealing with the principle of overdrive suppression, okay, one origin, okay, must generate the impulse at a time. Okay, all right. Okay, now If your origin, okay, for example, you've already located the origin, okay, that is SA node, okay, you have to use the word sinus, okay, as your first name, okay, all right, and this is very true, okay, if we are talking about the sinus rhythm, sinus bradycardia, and sinus tachycardia, okay. The three types of rhythms here, okay, are all coming from the sinus or SA node, okay? But of course, okay, we're not going to use the SA node, okay, but the sinus word, okay? So sinus rhythm, sinus bradycardia, and sinus tachycardia, the common denominator is obviously, okay, the word sinus, okay, because they are all, or the impulse generated, okay, are coming from the SA node. Clear? Right now, okay? Now, how can we able to choose between the rhythm, bradycardia, and tachycardia? Okay, so the second name, okay, has something to do with the rate, the calculated rate. Okay, right. We will use the word rhythm, okay, if the calculated rate is within the range of the normal inherent rate of the chosen, or within the normal range of the inherent rate of that pacemaker. Okay, for example, your calculated rate is 75. Okay, that is normal, okay, or within the range of the inherent rate of the SA node, which is 60 to 100. Okay, but okay, if your calculated rate is lower than the range of the inherent rate of SA node, then you have to use the word bradycardia. Okay, right? The same principle, okay, for the tachycardia. Okay, if the rate is more than the normal range of the inherent rate of SA node, you have to use the word tachycardia. Okay, as simple as that. Clear? Okay, now you have to copy this. Okay, I am giving you permission to have a screenshot of this. Okay, yes, because it has no copyright. It just came from me. All right. Okay, now if the origin of impulse is the AV node, okay, you have to use the word junctional. Okay, and these are the type of dysrhythmias under the AV node pacemaker. Okay, junctional rhythm, accelerated junctional rhythm, and junctional tachycardia. Okay, the principle on how we choose the second name, okay, is very similar to that of the SA node. Okay, we will use the word rhythm, okay, if the calculated rate is within the range of the normal inherent rate of the AV node, which is 40 to 60. Okay, so for example, your calculated rate is 45 or 50, okay, then you have to use the word rhythm. Okay, the normal inherent rate of the AV node is 40 to 60. Now, okay, if the rate gets a bit higher, okay, about 60 to 100, okay, you have to retain the word rhythm, because rhythm means normal to the body of an individual or the circulation of an individual, so you have to retain this. Okay, but instead of removing this or changing this word rhythm, you just need to add a word which is accelerated. It means that the rate of the junctional origin from 46C exceeds or accelerated to 60 to 100. Okay, and for the tachycardia, okay, of course, okay, if the rate is more than 100. Okay, all right. If the origin of impulse is from the His-Purkinje system, you have to use the word ventricular, right? All right. These are the three specific type of dysrhythmias from the His-Purkinje system: idioventricular rhythm, accelerated interventricular rhythm, and ventricular tachycardia. Idioventricular can be, or you can use a word ventricular here without idio, because in other books they are synonymous. Either idioventricular or ventricular. Okay, so it's the same principle. Okay, when you choose the second name, okay, you will use the word rhythm if the calculated rate is within the range of the normal inherent rate of the his frequency, which is 20 to 40. Okay. All right, and you use or you add a word accelerated. Okay, if the rate exceeds more than 40, but no more than 100. Okay, and ventricular tachycardia. Tachycardia is used, okay, if the rate is more than 100. Okay. All right. Disregard the ventricular fibrillation. Okay, we're going to talk about that later. Okay. All right. And finally, okay, the last origin is atrial. Okay, the cells of the, again, okay, just like what I've mentioned a while back, the cells of the atria, okay, can be the origin of impulse. Okay, though the difference of their nature to that of the nature of the three pacemakers, okay, is the absence of the inherent rate. Okay, the pacemakers of the atria cannot able to maintain its inherent rate. Okay, so it means that if the origin of impulse is somewhere in the atria, okay, multiple pacemakers or multiple cells are activated. Okay, and that is also the reason why, okay, we do not have an inherent rate, okay, because we have no focus of origin in the atrial pacemakers. All right, we actually have two dysrhythmias in under atria, okay, atrial flutter and atrial fibrillation. Okay, the only difference of the two, you cannot use rhythm here. You cannot use bradycardia. Okay, all right, because we do not have variations of the inherent rate. Okay. Okay, shape the atrial flutter need to recognize the sawtooth pattern of the P waves. Sawtooth. Okay, all right, and in fibrillation you have to recognize the wavy P waves. Okay, because what happens during flutter is actually multiple depolarization of the atria. Okay, so the ECG machine would record multiple consecutive P waves that will resemble the appearance of the sawtooth. Okay, all right, and during fibrillation, okay, the muscles of the atria are just quivering. So, what will be expected in the fibrillation is or are the P waves the irregular pattern, okay, and wavy appearance of the P waves. Okay. Okay. Now, supraventricular tachycardia is not basically included in the atrial origin, but when we're talking about supraventricular, we are not sure the exact location of the pacemaker. Okay, that is the reason why it is called supraventricular. What we only know about the supraventriculars is the pacemaker is above the ventricular. The supra means above. All right. Okay, and of course, okay, supraventricular tachycardia. This is only a single, okay, type of dysrhythmia. Okay, and since the rate is more than one. Okay, any question? Any question? Okay, now we've already know, okay, how to or what are, okay, the type of dysrhythmias under specific origins. Okay, but how can we able to locate the origins. Okay, so I've made I've made a table, okay, for the comparison of the parameters for the location of the origin. Okay, so we have 4 columns here. Okay, the first column, okay, is composed of the origin, sinus, junctional, ventricular, and atrial. Okay, and the 3 columns, okay, have different parameters. Okay, we have 3 parameters, okay, for the for locating the origin of impulse. Okay, the regularity, the P waves, and the QRS. Okay, now, okay, in regularity, okay, we only have 2 descriptions. It's either regular or irregular. Okay, I highlighted the irregular here because the irregular can only be a result, okay, of the atrial origin. Okay, so if the origin is sinus, junctional, and ventricular, you can always get regular rhythm. Okay, now jumping to the QRS complex. Okay, the only highlighted description here is the wide description, okay, from the ventricular origin. Okay, again, just can only is the only origin that can give a wide QRS complex. All are narrow. Okay, all right. The P wave dictates the differences of or the similarities of the other parameters. Okay, if the P waves are identical positive, then the origin is sinus. If the P waves are identical negative, then the origin is junctional. If the P waves are absent, then the origin is ventricular. And if the P waves are different, then the origin is atrial. So where is the supraventricular? Okay, the supraventricular, okay, has parameters that quite similar to that of the ventricular. Okay, the only difference, okay, of the two, okay, ventricular and supraventricular, is the QRS complex. Since the supraventricular's origin, okay, can be coming from above, okay, the ventricle, okay, it always give us the narrow QRS complex. Okay, so the bottom line, okay, for the QRS complex differences is the ventricular origin, okay, can give us, or only the ventricular origin can give us the wide QRS complex. Okay, all right. Any question? Confusing, but if you focus on the differences, you can easily get. Any clarification for this? Okay, now we are on the last part, okay, of our discussion, okay, the workshop. Okay, all right. So what I would like you to do is every time I give an example like this, is you have to give me the name of the rhythm or dysrhythmia. Okay, for example, okay, for this example, okay, I will give the name, okay, of this reading. Okay, always follow the 5 steps and the last step, okay, which is the origin. Okay, so the rate, okay, of this lead, or the heart rate, okay, from this lead is 75 to 100. The rhythm is clearly regular. The P waves, this is the P wave, the first P wave, okay, compared to the succeeding P waves, the description would be positive and identical. Okay, the PR interval, okay, is normal, about 4 small squares in width, okay, or the length is 4 small squares, that is normal. The QRS complex is 2 small squares, so this is normal. Okay, so now, okay, how would you get the origin of the impulse? Okay, you need to use the rhythm, P waves, and the QRS complex. Okay, all right, so referring to or using the table, okay, typically column, what are the either the sinus, or the sinus, junctional, then and ventricular. Okay, so since the atrial origin can give us irregular, okay, we will eliminate, okay, the atrial from from the choices. Okay, all right. Now QRS complex. The QRS is narrow. Okay, so what are the origins that can give us narrow QRS complexes? Sinus, junctional. Okay, atrial can give us narrow QRS, but it is already eliminated into regularity. So the choices narrow down to two, sinus or junctional. Okay, the P waves again, okay, is the specific parameter, okay, that can give us the exact origin, okay, of impulse. Okay, and since the P waves are positive and identical, okay, and it says on the table that if the P waves are positive and identical, we have sinus origin, right? Okay, so we have sinus origin here, but how would we choose among the three second names? Okay, rhythm, bradycardia, or tachycardia. Okay, again, okay, the second name has something to do with the calculation of the rate. Okay, all right, and since the rate, okay, of this lead is 75 to 100, that is within the range of the normal rate of the SA node, we will use the word rhythm. Okay, so combine the two sinus rhythm. Okay. All right, the sinus rhythm is the only rhythm that is normal. Okay, all other rhythms shall be called dysrhythmia, even if the type of dysrhythmia is benign. Okay, we have to consider those as still, okay, dysrhythmias. Okay, what I'm talking about is the sinus tachycardia and sinus bradycardia, because sometimes the patient may be symptomatic for this type of dysrhythmias. Okay, but we always consider these as dysrhythmia. Again, the sinus rhythm is the only rhythm, normal rhythm, okay, that we have. Okay, now our time is 2:56. Okay, maybe we can have our third 10-minute break, okay, so that we can or we yeah, it's 2:56. Okay, we will resume, okay, up to the last slides, okay, after our 10-minute break. Okay, okay, I will leave this slide to you, okay, in order for you to internalize, okay, how to use the 5 steps or the 6 steps, okay, in analyzing the dysrhythmia. Okay, 2:56, we will return at 3:06. All right, I will be waiting for your answers, okay, for the picture that I'm going to flash, okay, on the screen. This is the first picture. Yeah, give me the name of this dysrhythmia. Sinus bradycardia from Julius Bernard. Yes, okay, very good. This is sinus bradycardia. All right. Next. Sinus tachycardia from Janice. Yes, okay, it's so quite fast. Okay. All right. What about this one? SVT or supraventricular tachycardia, okay, from Julius Angel. Yes, okay, yes, okay, because yes, for the benefit of all, okay, it has no P wave, okay, and according, okay, to the table that I gave to you, okay, there is no P wave, okay, and the rate is more than 100, then we have supraventricular tachycardia. All right, what about this one? Still SVT, yes, Angel, you got it right. Okay, all right. It is the same, okay, with this example. Okay, all right. This example are narrow, and this is just a T wave, no P wave, right? Though uh, the, the two pictures, okay, are not the same, but the descriptions. Okay, so you always analyze the description, okay, according to the descriptions, not on the comparison to other pictures. Okay, that is not recommended. Okay, all right. What about this one? Atrial flutter. Yes, Julius, it's atrial flutter. Okay, right. We can clearly recognize the flutter P waves. Okay, the solid appearance of the P waves here. Okay, all right. Yes, Jazreal. Okay, it's atrial flutter. Kambal. Okay, Maria Constellation. Okay, this is atrial flutter. All right. Now, if what about the rate? Can you give me the rate of these of the atrial flutter? Can you give me the rate? Yes, it's more than 100. Okay. All right. So if you have an atrial flutter or atrial fibrillation more than 100, okay, you have to recognize the type. Okay. All right. This type is rapid ventricular rate. Okay. So if the rate is less than 60, okay, it shall be called atrial flutter or atrial fibrillation in slow ventricular rate, right? Because we do not give any anti-dysrhythmic medication for slow ventricular rate. So you need to recognize whether it's rapid or whether it's slow. Okay. All right. What about this one? Are you sure? Well, most of you are you do we have wavy P waves here? Do you have flattened small pointed P waves here? Okay, Julius, Regina, yes, just still flutter. Okay. All right. We can clearly see the the P waves here. Okay. In atrial fibrillation, we cannot able to recognize the pattern of the P waves. Actually, okay, if you remove the QRS complexes here in your imagination, okay, you can still get the solid appearance, okay, or the solid pattern of the P wave. Okay, so this is still an atrial flutter in rapid ventricular rate. Yes, Julius, okay, it's flutter. Okay, but can you give me the rate of these atrial flutter? Because we have an atrial flutter in rapid ventricular rate. What about this one? Okay, it's yes. Well, actually, yes. Yes, 80. Okay, right, we have 80. Okay, but we can consider these as ventricular rate. Okay, if you notice the mark here, okay, are you seeing my cursor? Okay, there is a mark at the top of the ECG paper. Okay, another mark here and another mark here. Okay, if you have markings at the top of your ECG paper, okay, that's where you have to um you have to use this, okay, in order for you to get the 3-second strip or the 6-second strip. Because from here to here, okay, you can get 15 big boxes, and from here to here another 15 big boxes. Okay, so you have to start here. Okay, so from this mark to this mark, you only have 3 small square. Basically, okay, we have 60 bits per minute. Okay, yeah, 60. Okay, so this is atrial flutter in slow ventricular rate. Okay, all right, what about this one? No, this one. That's easy. Yes, Julius. Okay, so see the difference, okay, of the P waves. Clearly see the differences of the P waves of these atrial fibrillation, okay, to the P waves of the atrial flutter. Okay, the P waves are very chaotic. Okay, it means that you cannot able to recognize clearly where the P waves are. Okay, compared to the atrial flutter, okay, there are pronounced P waves. All right. Okay, if you remove the QRS complexes in your imagination and you connect the lines, okay, the line is wavy, okay, and it represents, or it is a figure of religion. All right, this one. Yes, Julius is atrial fibrillation in rapid ventricular response. Okay, all right. In this example, okay, the P waves are recognizable but still wavy. Okay, right. So in this example, okay, the P waves are recognizable in this part, okay, but in this part, okay, we have few P waves that are wavy here, okay, and here, okay, the the wavy P waves can be clearly seen. Okay, all right, now guys, I want you to remember this principle. Okay, in atrial fibrillation, okay, the P waves may be identifiable, okay, or with fibrillatory waves. Okay, so when we are talking about unidentifiable, okay, it means that you cannot see P waves at all. all right? Because sometimes the quivering motion of the atria, okay, cannot be sensed by the ECG machine, okay, if, okay, the motion of the quivering is too weak to be recognized, okay? So it means that the ECG machine cannot record representation waves, okay, for the fibrillation, all right? Okay, so again, the P waves can either have fibrillatory waves or no P waves. All right. Okay, so do not be confused with SVT, because SVT has no P waves as well. The difference, okay, of the fibrillation and the SVT is the regularity. Okay, SVT shall always be or should always be regular without P, while in atrial fibrillation it is always irregular and sometimes no P waves. Okay. All right. What about this one? Ah, already done. I'm sorry. What about this one? Thank you so much, Julius. Okay. All right. What about this one? You have to be very careful analyzing the regularity. Is it regular or irregular? Is it regular or irregular? Yes, Annabelle, it's irregular. Okay. All right. Try to focus on this interval. Is it similar to the interval? This interval is quite longer than the first one and the second one, okay? And it is repeated in this part, okay? Quite more prolonged, okay, than this part, okay? All right, okay, so this is irregular, okay? So it cannot be always regular, right? Okay, so you always have to always look into the regularity because it means a lot, right? So given the regularity as irregular, okay, so how would you analyze this lead? Atrial fibrillation, yes, Maria Consolation and Julius. This is still an atrial fibrillation in rapid ventricular response, okay? All right, you only have T wave in between QRS complexes. Okay, there is no P wave, so the waves are absent. It is not a sinus tachycardia, definitely. All right, what about this one?
Irregular. Irregular.
Yes, this is irregular. Okay. Come on, guys, you have to follow the steps to come up with a name. Janice, it's AFib. Yes. Okay. Very good. Okay. All right. RDS, it's AFib. Okay. So how did we come up with atrial fibrillation? Actually, this is atrial fibrillation in slow ventricular response. Okay. All right. The rate is 30 to 40. Irregular. Okay. So irregular. Okay. It means that we have to choose the atrial. All right. Okay. Sinus, junctional, and ventricular are all regular. Okay, we have a clue. Okay, the first name is atrial. Okay, the P waves are absent. Okay, all right. So in what type of dysrhythmia, okay, does the P wave can be absent? Okay, so actually we have two types of dysrhythmias in which the P waves are absent. Okay, SVT or atrial fibrillation. Okay, but this cannot become an SVT because the rate is 30 to 40 only. All right. Okay, this is what I'm trying to say a while back. Okay, the P waves are absent, irregular. Okay, but the rate is very slow because so it's slow to rate in atrial fibrillation. All right. Okay, what about this one? No, this is not a premature atrial contraction, Clarizel, because um we have a shortened interval here, and we do not have a P wave in some areas of the tracing. Yes, Julius, it's atrial fibrillation in slow ventricular response. Okay, atrial fibrillation. Okay, we do not have a P wave or clear P waves that can be considered. Anyone, guys? AFib and Angel. Okay. Clearly identify P waves that are wavy. Okay. Right. The P waves are in all areas of the cardiac cycles. Okay. All right. What about this one? Go back to your 5 steps. Come on, guys. Go back to your 5 steps. You are missing one principle. You're missing one step. Okay, let me help you. Give me the rate. Well, you have to use the precise rate calculation. It can be used here. 40s, yes. Okay, what about the regularity? Is it regular or irregular? Regular, yes, Janice. Okay, what about the P waves? What is the description of the P wave group?
Negative.
Negative, yes. Okay, negative P waves, right? Okay, this is a negative P wave. All right. Okay, because yeah. Okay, what about the QRS complex? Okay, it's still narrow. Yes, still is. Okay, we are junctional origin. Okay, so junctional what? Okay, give me the second name. Okay, because we already have the first name. Okay, junctional what? Junctional what? Okay, junctional. Okay. I think iophobidicardium is only used by sinus. Okay, so yes, rolling. We have negative P wave because we have junctional origin, Okay, but what will be the other name? Accelerated junctional rhythm. Yes, Maria Consolation. Okay, we have accelerated junctional rhythm. Okay, we cannot consider this as junctional rhythm because the rate is 40s. Okay, or I'm sorry, it's 80s. Okay, 300, 150, 175. It's 75 to 100. All right. Okay, so in this functional rhythms rate, it's a bit higher. Okay, but it's not more than one. Okay? It's an accelerated junctional rhythm. All right. Okay. In this rate, the junctional rhythm normalized, so the patient's condition gets or is getting better. Okay, or the signs and symptoms are or the vitals are stabilizing. Okay. What about this one?
Yeah. Regular negative periods.
Junctional tachycardia. Okay, yes, Maria Consolation. Okay, junctional rhythm. Okay, all right. Next, idioventricular rhythm. Yes, Julius.
Regular.
All right. Okay, the rate is 30s. Regular rhythm, no P waves, and with um wide QRS complex. Okay, that's what makes it the idioventricular in origin. All right. What about this one? By the way, in ventricular in origin, okay, the QRS complex is always opposite to the T wave. Okay, so these positive deflections are the QRS complexes, while the negative deflections are the T wave. Okay, there is a true ventricular origin if the QRS complex is opposite to the T wave. Okay, so if the QRS complex is negative, the T wave will be expected to deflect in a positive deflection. All right. How about this one?
Regular negative periods.
No, accelerated idioventricular rhythm. Okay. All right. What about this one? Yeah, this is your favorite, the ventricular tachycardia. Okay. All right. Yes, the actually it's 150 to 300 regular rhythm absent periods because we only have a QRS complex that are negative deflection and the T waves, okay, that are positive deflections. Okay. All right. We have two types of ventricular tachycardia. Okay. This one is monomorphic ventricular tachycardia. Okay, mono means one, morphic means morphology or sizes and shapes. So if the QRS complexes have the same sizes and shapes, then we have monomorphic ventricular tachycardia. All right. Okay. This one is a polymorphic ventricular tachycardia because the QRS complexes vary. Okay. With the sizes and shapes. Okay. Other complexes are small while the others are large. Okay, so this is a ventricular, or this is polymorphic ventricular tachycardia. Now, this is what we call the torsade pois. Okay, the torsade pois means twisting of points. Okay, twisting, the torsade means twisting, the pois is the points. Okay, all right, it means that it looks like a party streamer. Okay, where you can find that where you can find portions that are large, okay, and small, large and small. Okay, just like this one. Okay, we have large complexes here, followed by small, followed by large and small. Okay, that is the torsade pois. You have to recognize this form of polymorphic ventricular tachycardia because we have a specific medication for this one. All right. Okay, we have actually 8 forms of polymorphic ventricular tachycardia, but the torsade pois is the form that is very common. Okay. Okay, it is what you can get. Okay, in torsade pois. Okay, it's just like a seismograph. Are you familiar with the seismograph? Okay, how the seismograph is how it's recorded. Okay, all right. Now, most of the practitioner misinterpreted the torsade pois has a pattern. Okay, the pattern is just like a party streamer. Okay, that is rotated. Okay, while the ventricular fibrillation is just like these. Okay, it means that there is no discernible is rapid and chaotic. Okay, the P waves are not discernible as far as the QRS complexes. Okay, it means that if you want to know, okay, what is happening in our heart, okay, the ventricular muscles are just quivering. Okay, so imagine how the ECG machine can record a quivering motion of the muscles. It's just like that. Okay, no pattern of no pattern at all. Okay, all right, and usually it will not, or the size will not exceed 10 small squares. Okay, unless you amplify the sensitivity of the machine. Okay, it would increase its voltage. Okay, but in regular sensitivity, that's what you can get. All right. Okay, ventricular fibrillation is under the cardiac arrest rhythms. Okay, we have 3 categories of dysrhythmias actually. Okay, we have bradydysrhythmias. Those are the dysrhythmias with rate of slow, and we have the tachydysrhythmias. Okay, those are the dysrhythmias with rate of more than 100, and we have the cardiac arrest rhythms. Okay, these rhythms are the cardiac arrest rhythms are the rhythms without pulse. Okay, so that's the reason why it is called cardiac arrest rhythms. Okay, and these are the ventricular fibrillation, pulses ventricular tachycardia, asystole, and PA. All right, now, okay, in ventricular tachycardia, okay, if you have a ventricular tachycardia, well, actually, all of the rhythms and dysrhythmias, okay, must have a corresponding mechanical therapy assessment. I mean, mechanical activity assessment. Okay, I've mentioned on the first part of our discussion that we have 2 activities of our heart. Okay, the mechanical activity and the electrical activity. In order for us to assess for the electrical activity, okay, we need to obtain the ECG, or at least connect the patient to the cardiac monitor to know if there is an electrical activity. Okay, but if you want to assess for the mechanical activity, okay, you need to check the pulse of the patient. Okay, that's how we assess, okay, for the mechanical activity. Now, okay, if you have a ventricular tachycardia, okay, you cannot analyze a ventricular tachycardia, okay, without checking for the pulse, okay, especially, okay, if the patient is unconscious, right? Okay, if you see a ventricular tachycardia and the patient is unconscious, okay, you need to check for the pulse, because if the patient has no pulse, okay, it must be called pulseless ventricular tachycardia. All right. Okay, the same with the PEA. Okay, all right. asystole, okay, is the absence of electrical activity. Okay, it's just an isoelectric line that is recorded, okay, by the machine. Okay. The PEA is or stands for electrical activity, can be any of the dysrhythmias, okay, that we've discussed. Okay, all right. It can be sinus rhythm, but if the patient has no pulse, it must be called pulse electrical activity. So again, any of the dysrhythmias that we've discussed, if the patient has no pulse, it must be quite name of pulse electrical activity without checking for the pulse of the patient. All right. Okay. So that concludes our discussion for the ECG or clarification regarding the topic. ECG for 3 hours or sometimes 2 hours, 2.5 to 3. Okay. But since I enjoyed your responses, okay, your participation, okay, I talked a lot. Okay, this is unusual. Okay, can you open your cameras? Okay, thank you. I'd like to thank all who participated in the question and answers in the workshop. Okay, so thank you so much. I hope you understand the principles that I discussed to you. Okay, that's I think the easiest way to discuss the ECG. Okay, because ECG interpretation is very hard. Okay, to internalize and understand. Okay. Okay. Any question? Question? Ace J, how's the war? You were holding a machine gun a while ago. Okay, so how's the war? Okay. Any questions? So, thank Okay. All right. Some of you are too shy to show their faces. We'll see you tomorrow at exactly 8 a.m. Okay. I usually continue the discussion with the bradycardia and tachycardia algorithm, okay, but I think you are all exhausted with all the participations, and yeah, I will ask for your permission, okay, to end this discussion because I'm quite sleepy. It's 4 o'clock in the morning here. I still have my duty at 10 a.m. Okay, but I would get few more hours of sleep, okay, before I go to work. Okay, but still we still have 11 minutes to 4, okay, to address your concerns and to answer your questions, okay, or some clarifications. Okay, you're welcome all. Any question?
No more question.
No more question. Okay, all right. Okay, if there's no more question, we will continue tomorrow at 8 a.m. Okay. Tomorrow will be a very light discussion because we will be playing a lot of video presentations. Okay. Because yes, okay, we are just online. Okay, and we don't have any practical demonstration. Okay, so it's advisable to play videos so that you will not get bored. Okay, looking at my or um, following what I'm talking about. Okay, and yeah, okay, you will be you will not get bored tomorrow. Okay, because there's a lot of video presentation. Okay, so thank you so much. If you do not have any question, okay, we can end this discussion. Okay, and we pump admin. Okay, I am going to give the floor to you. Are you there? Of course, you're there. We pump.
Thank you, sir.
Yes, thank you very much. Exactly. See you tomorrow at exactly 8 a.m. Okay. Yes, we're not gonna be late tomorrow. We will start, okay, without the others, even if I only have 2 or 3 participants, okay, at 8 a.m. okay, we will still start, okay, on time. All right. Okay, so thank you so much.
Thank you. Bye-bye.
Bye-bye, and thank you very much. You're welcome.
Thank you po ulit, sir. Tomorrow po, same link ulit po. Bukas po.
Oh, wala.